You can start, sir.
One
We are
minute.
live now.
Yeah, 1 minute. Shinoy sir is there. Just 1 minute. Good afternoon, Rimzin ma'am.
Sachin, should we start?
Sir, 1 minute just.
Chennai sir join झाले.
झाले का? हाँ.
I can see.
Shinoy sir? Now you can start.
Hello, good afternoon, everyone. Piyush?
I think you are audible.
Yeah, but जे YouTube live वरती आहे ना, त्यांना audible नाही होत आहे पण. Good afternoon, everyone.
Good afternoon.
Good afternoon, everyone, and welcome you all from BEAD Academy of Pediatrics and BEAD Indian Medical Association.
Good afternoon, sir.
At the outset, I would like to thank Central IAP, Dr. Bhaskar Sinai sir, Dr. Sachin Patil sir, for giving us opportunity, a small branch from Maharashtra to conduct a module on hepatitis A. This is, I think, the first module that we are taking in Maharashtra since the new body is being formed. I would like to invite Dr. Bhaskar Sinha sir to have a few words to encourage us.
Thank you, sir. Thank you for taking up this project. In fact, I'm very happy to see that this project is being launched and this module is being taken up very well. I first of all thank the Central IAP led by the previous team and the present team for giving me an opportunity to frame this whole module and then take it forward. In fact, this is a very interesting module wherein practical module wherein lot of experts have put their efforts in that and they have made it very nice. We have faculties and the creator of this module, I mean, Dr. Rimjim Srivastava, Dr. R.K. Gupta, Dr. Ravi Shankara, Dr. Basavaraj, and so many well-known people across the country have contributed to forming this. And the conduct of this program has been ably assisted by Dr. Sachin Patil, who has been my right hand. And then, in fact, this module speaks about the epidemiology of this one, hepatitis A. Then what are the clinical features, and then how do we approach a case? And these are all depending on a case-based module. This is more of a case-based module. Then how do we prevent? And we have vaccines. How do the vaccines we can utilize optimally in our practice to see that the population is prevented from this disease. Though we say hepatitis B is a very mild disease, without medicine also it goes, but still there are a percentage of people who have gone through serious problems. They can even give rise to acute hepatic failure and other things. It's not that all this innocuous as it has been told and taught, but even if you look at the Nelson textbook, there is a mention that about 10 to 15% of them with the hepatitis A can develop complications. And these complications are more in those who are immunocompromised or those who have underlying chronic liver disease, wherein it can become more severe problem. So with this brief introduction, I once again thank you all for joining and making this project to go on. Thank you so much.
Thank you very much, sir. Now I would request Dr. Subhash Joshi, sir, President, BEAD Indian Academy of Pediatrics, to have few words and welcome everyone. Joshi, sir.
Good afternoon, everyone. First of all, I must welcome you all for this module of hepatitis A, which is conducted by BEAD Academy of Pediatrics along with IMA BEAD. And I think this is my second term, but I have got a very enthusiastic secretary like Sachin. And due to that, we are able to arrange this module. And this is a very, I think, today's program is a successful program. There are so many viewers, there are so many registrations. But I must thank Central IAP as well as Maha IAP, who have given us the chance to conduct this webinar. And Dr. Bhaskar Shenoy, Central IAP, Dr. Hemant Gangolia, President Maha IAP, and Dr. Amol Pawar. I must thank all of you to give this chance to BEAD Academy of Pediatrics to conduct this module. And today we are having many eminent speakers who will talk on hepatitis A module. Actually, hepatitis A is a very easy disease, and we are seeing many cases. And if it is treated properly, there is no complication. But if there is something wrong, then patient suffers very much. And we have seen, all of us have seen many such cases. So this is a very useful webinar. At the onset only, I must thank Dr. Bela Verma, Dr. M. G. Srivastav, Dr. Ravi Shankara, Dr. Raj Shekharan, Dr. Narendra Naniwadekar, who are going to give lectures henceforth and update our knowledge. So I welcome all, and I thank all the dignitaries, and I will give mic to again Secretary our Sachin.
Thank you, sir. I would like Dr. Pangrikar sir, Anurag Pangrikar sir, who is the President IMA and is a pediatrician and past Secretary of BEAD Indian Academy of Pediatrics, to have few words. Without his support, I would not have been able to conduct. I would not have been able to give a MMC credit point to all of you. Pangrikar sir.
Thank you, dear Sachin. On behalf of Indian Medical Association BEAD, I welcome you all for this hepatitis A module, which is the necessity for branches like BEAD, which is to be called as a rural area branch. Basically, I am a pediatrician, so I am looking all the familiar faces who are academic stalwarts presenting for BEAD. I won't take much time, but I will say this module would be useful to unlearn the things which we have wrongly learned. And if we do that, that would be a great thing for our patients. Thank you.
Thank you, Pangrikar sir. Now I would like President Maha IAP, Dr. Gangolia sir, to have few words. Gangolia sir, welcome.
Thank you, Dr. Sachin. At the outset, respected dignitaries and faculty on the Zoom dais, good afternoon, each and everyone. And it's very happy to know that small branch coming forward to take up this module, viral A hepatitis module. And as said, more often we in our OPD we come across the cases of the hepatitis. आणि आपल्याकडे बऱ्याच वेळेला असं असतं आम्ही एक गावठी औषध करून आलोय आणि एक गावठी औषध घेतोय आणि नंतर मग आपण ट्रीटमेंट करायची कसं काय करायचं ते बऱ्याच काही गोष्टी असतात त्याच्यामध्ये and we missed off most other things that we have to do it with that. But what I feel, may I suggest, because this module is always, any module for that matter is always having 4 hours, 6 hours. Can we have academic pearls from these modules in form of algorithm, which will be useful in day-to-day practice for the general pediatrician practicing at the peripheral rural settings? So, so we can have a brief things which will be very useful in the practice. I do not know whether it is practically feasible or not, but this is a suggestion from my side. And with that, all the best wishes to IMA, this IAP BEAD branch to organize. Also, I will like to acknowledge the presence of our executive board members, Dr. Bela Verma, Madam, Dr. Nani Vadekar, sir, and as well as my good friend, Dr. Anurag Pangrikar, who is always there as the IMA president, and hearty congratulations to our president, Dr. Subhash Joshi, sir, and Dr. Sachin of the IAP BEAD branch. And I am sure that this module will be a huge success and it will be very beneficial to all the attendees. Thank you very much.
Now, thank you, Gangolia sir. Despite busy schedule, you have given your valuable time to have few words. Now, I would like Dr. Amol Pawar, sir, Secretary Maha IAP, to have a word of wisdom.
Thank you, Sachin, for inviting Maha IAP also on this platform. I thank the Central IAP President Dr. Ramesh Kumar sir and his team for allotting this module to BEAD. This is the first Central IAP module in this year 2022. I congratulate Dr. Bhaskar Shinoy, Dr. Sachin Patil, his right hand, and all the team members for taking time for this module. And I congratulate BEAD IAP team as well as BEAD IMA team for this module. Thank you.
Now, backbone of this module, Dr. Sachin Patil will say few words. Sachin.
Yeah. Good afternoon, everyone.
Dr. Sachin Patil, you are doing very good work. Sorry to mention, not to mention your name.
No issue, sir. No issue. Good afternoon, everyone. I wish to extend my deepest respect and appreciation to the esteemed CIP team, especially President and Secretary and all CIP members. At the same time, I thank you so much for the Maha IAP team for giving this opportunity. And a special thank you to the Bhaskar Shah having a faith on me. And now special thanks to Sachin Jetlia. He is my close friend for giving the opportunity of this module to be presented at the so small branch. And it's the first branch to act as a central IAP module in Maharashtra. So many congratulations the team BEAD. Now, without wasting much time, we will start further proceedings. Over to you, Sachin.
Thank you, Sachin. Last, we have a EB member from Maharashtra IAP, Dr. Bela ma'am. I would like her to have few words.
Hello. Yeah, I have joined.
Yeah. Good afternoon, everyone. I think it's really needed module because most of us focus on hepatitis B and very little, is known or taught to us about hepatitis A, which, as sir said, Bhaskar sir, it is taken as a mild disease. It will resolve. So I think the management and the awareness and the vaccination about this hepatitis A needs to be spread across all our pediatricians and practicing doctors. So I'm looking forward to the entire module, which is going to be a new thing for us also. Wishing you all the best. Thank you.
Thank you, ma'am. I would like Dr. Sanjay Deshmukh sir to have a word.
Good afternoon, everybody. All respected faculties for this module. Dear President, Dr. Ramesh Kumar ji, all my respected all EB members, dear Secretary Dr. Vinay Saxena ji, and all the dedicated team of Hepatitis B module, which is working on this concept, so that, as rightly told by now just now below, madam, we have to make sure that this module should be reached to the every smaller branches also. That I always believe. And thanks to team to making this happen. So my best wishes to team Hepatitis B module. Okay. Thank you. Thank you.
Thank you, sir. Now we will start with the module. I would like Dr. KP Srikanth sir to start his first session, Hepatitis A virus and disease. I would request Dr. Naniwadekar sir, Narendra Naniwadekar sir, to moderate the session. He will introduce Dr. Srikanth sir. Dr. Naniwadekar sir is a Maharashtra Executive Board member for 2022. He is from Kolhapur, and he will introduce Dr. Srikanth sir, who is the first speaker for this session.
Yeah, thank you. Thank you for giving me the opportunity for being a chairperson. Dr. Srikanth is the pediatric gastroenterologist who is worked with PGI MER, and is a consultant at Manipal Hospital, Bangalore. And I'll not waste my words. I would like Dr. Srikanth to start with his speech. Dr. Srikanth. Hello.
He is there. I think Srikanth is there now. Yeah.
Yes. He would be talking on hepatitis A virus, the disease. So the basic will be discussed by him.
Dr. Srikanth was there.
He was there. Now he is logged out, I think.
Just let me find out. He's in the next cabin.
He had already shared his screen.
Yes.
Probably he must have lost his.
Just a minute, I'll check.
Yes, please.
He joined now.
He's sitting in the next room.
You cannot be in the same room, otherwise it will be echoing a lot.
There appears some problem technically because in front of his name, either mic or video camera is not shown in the participant list.
May we request him to come to your, yeah, he has come.
Screen is visible, but he is not audible.
Nishant sir, you are not audible.
Probably net problem is there, Dr. Srikanth.
Srikanth sir, you are not audible.
Now it is audible, visible. I don't know.
Any net issue?
Next room, then can we just come to he's with whom? Right? Sir,
Just stopped it.
is he with? Yes, sir.
I'll start the video because the host had stopped it.
Okay, okay. Digitization person is there. He had stopped sharing video of sir. Digitization person.
Yes, sir, I can see that.
No, he will join again. He will join again. He has logged off because in his system it is seen, but we are not able to see. I checked it. He is again logging again. Yeah.
He's online now.
Okay.
Sir, can we? Yes, sir. Just a minute. Hello, Shinai sir. I think there is a technical issue, so we can start second session of Rajsekhar sir. Hello, sir. Please unmute. Shinai sir.
I think you can start the second. By that time you will be ready. Yeah.
Yes, sir. Rajsekhar sir is there. Sachin. Ha.
Good afternoon, sir. We will start with the second session by the time first session will be ready. I would like Dr. Rajashekaran sir, who is the Associate Medical Director and Senior Consultant Pediatrician, Giggles by Omni Hospital, Visakhapatnam. He is an active member of IAP from 2000. He's worked as Secretary, Vice President, and President of IAP Visakhapatnam branch. He's a past executive member of IAP Andhra Pradesh State branch, and he's the present secretary of IAP AP State Infectious Disease Chapter. He's an executive board member, Central IAP 2021. Sir, over to you.
Thank you, sir. Thank you, sir, for the nice introduction. I'll be sharing first, sir. Able to see the slides? Sir, are you able to see the slides, sir?
Yes, sir.
Yes, yes.
Able to hear.
Yes.
Sorry. Full screens I am trying.
I would request Sanjay Deshmukh sir to moderate this session.
Thank you, Dr. Sachin. We'll continue. Thank you.
It's not getting now able to see, no, sir?
Yes, sir. It is full screen now.
Sir, first of all, I express my heartfelt thanks to the Central IAP team, Dr. Upendra sir, Dr. Ramesh sir, and Dr. Vin Saxena. And finally, our Dr. Bhaskar Shenoy, the national coordinator, the national coordinator, sir. His smile gives us the encouragement to carry on the module throughout the country. I thank Dr. Sachin, who has been with me for last year, and because of his encouragement, I'm being able to go through this module and disseminate the knowledge. I thank the team IAP BID and team IAP Maharashtra for giving me this opportunity to be with you all, share your experiences, share my experiences for the next half an hour. Thank you. So my topic that has epidemiology in India. The moment we think about the SPM, when I thought of this topic, everyone will start sleeping. Because as a clinician, we are not interested what is epidemiology. क्या करना है epidemiology में? Disease पता है, चलो काम करना है, वैक्सीन देना है, ट्रीटमेंट करना है. Thought में चले जाता है. But if we are not thinking of the epidemiology, then how do we know about the disease? How do we change the patterns of understanding of the disease? How do we see that some changes has to be made in the disease schedule, I tell you, the prevention schedule, vaccination schedule. So the importance of epidemiology lies in this. So understanding of epidemiology is also very important, like we understand the clinical subject. So what is the epidemiology? As we have already discussed, as the panel, as the president, secretary, everyone has discussed, the disease of mild impact, mostly asymptomatic. Then why to bother about it? See one thing, when I was a resident, in the senior resident in Delhi, one child had come to our hospital and the child we diagnosed as case. It was a fulminant hepatitis and the child died. So, a disease, a mortality of fulminant hepatitis is 0.03 to 0.4. Then why should we bother about this? But for that parent, that child is 100% important. So if it is point also, a disease which causes a mortality, some cases, and a disease which can be prevented by taking the appropriate preventive steps and by vaccination, why should we neglect that disease? Thinking that 90% nothing happens. Now it is at 90%. Is there a where we have to see that it is not 90, it is 99.999. Our knowledge is being evolved. So 1.5 million clinical cases per year. बहुत छोटा है. I told you the importance of this when it comes to a single child, when it comes to a child as alone, standalone. But is more. See, we here are around 200 pediatricians here. We see lots of cases. But how many of us is reported? I have not reported many. Do my work. So it is not 1.5 It's written 10 times. I don't use 100 times more because we are underreporting cases. So what now I was telling, epidemiology is important. Why it is important? Number one, the hepatitis A infections have been increasing. It was 4.2% in 2005. Now it has been increased by 4.2% between 2005 and 2013. A disease which is increasing, a disease which can be prevented, why not be taken action? That is the most important. WHO estimates that in 2016, 7.34% died from hepatitis C worldwide, accounting to 0.5% mortality. But it is correctly reported that are more and more. Next question. Let's go to the background. World incidence, as we have discussed, 1.4 million cases, but it is much, much more. I was giving example of the permanent hepatic failure. An uncommon complication activity is only 0.14 to 0.35%. In the magnitude of the population, crores and millions of population, the magnitude is very less. But once it comes to a particular child, then it is 100% you have to think. It is fact. And when it was a study was done in North European countries, 20% of the cases of vulnerable viral hepatitis is due to hepatitis A. So now 20% of the cases, 100 cases of hepatic failure has been taken, and viral hepatitis is 50% of weight loss. So viral hepatitis is one of the important causes. Then, as age increases, the understanding epidemiology, as age increases, acute hepatitis, fulminant hepatic failure, severity also increases with the age. So again, understand the epidemiology. Now epidemiology is shifting towards the adolescents and the early age children. So if the severity is increasing, we should see that these children that they should not get severe. So we have to prevent this shift, not to do bad in our society. If you see the prevalence, you see high prevalence, greater than 90%. Greater than 90%, you see, it is in India. So if prevalence declines by age of 10 years, intermediate prevalence, greater than 50% have immunity by age 15. As the prevalence decreases, less than 50% have immunity by the age 30. Okay, so as the prevalence decreases, immunity as the age increases decreases. I told in the first slide, the severity increases in that age group. If the child is affected by hepatitis A virus in the early age group, infant age group, second age group, the severity is less. But if they are affected as the age increases, the severity increases, fulminant hepatic failure increases, all this. So this we don't need. How is hepatitis A classified? It is classified as a low endemicity, limited endemicity, and high endemicity. What is taken? Seropositive rates, seroprevalence, seropositive. If an area is having less than 15% seropositivity, it is low. If it is the seropositive rate is 15 to 50% in that population, it is known as intermediate endemic area. If the seroprevalence is more than 50%, it is known as an high endemic. So that is the way we have classified high prevalence, intermediate prevalence, and the. What are the high endemic areas? I have shown you. Southeast Asia, Central America, and South America. So these are the highly endemic areas. But now what has happened? In China and India, the high endemic, these countries, especially we are in India, we should think of India, is shifting towards the others. You see the burden of take a total hepatitis A cases. You see here, if you're taking a total hepatitis A cases, these are the number of hepatitis A cases. Hepatitis A, positive for hepatitis A, it was in 2012, 2013. This is the way the graph has been going. So total number of hepatitis cases, if you take a group, let's see in 2011, 2012 group, 2013 group, you see, in case of 2012, 1 to 13, 40 to 50 degrees. But now let's see what is happening in 2013. It is thick as the age increases. That is 27 to 39, 40 to 58. Okay. What is hepatitis A epidemiology going? Is the reservoir? The human being is the reservoir. How it is transmitted? Fecal route is the transmission. Is the when the person is infected, is the index case A, then how many people he'll affect before and after. For that, the communicability is important. Understanding of communicability is important. 2 weeks before he must started treating the virus and he must be infecting it before to 1 week after the onset of symptoms. So today, if patient A has fever, so he has started communicability has started 2 weeks before, and it will complete after 1 week of the onset of symptoms. So there is a changing epidemiology of hepatitis A virus. So what is the changing epidemiology? This part is very important in understanding. So I was talking about a high endemic. See what has happened in the last year. There is a shift from the high. If there is a shift, what is happening to me? No, there are much things lying down. Importance of this is very much evident from the decreasing number of adolescents and young adults with prior exposure. Those were the days 15 years and years back. Asymptomatic infection. By the time they are in this age group, adolescent young adults. But today, this understanding, our children in a higher socioeconomic status or middle economic status, we are carrying all the water, we are safe, we don't we take care that everything is carried everywhere. Water is there. So these children who are going to the hostels, they are prone for hepatitis A. And if they are prone for hepatitis A, the severity is more, the complication is more. This understanding one has to get it. Hepatitis A remains highly endemic in rural areas, highly endemic still, because the facility of sanitation is less. And is a potential source of fear because it is endemic. Once someone goes to the rural area and this child or this adolescent goes to a trip in the college hostel, goes outside when he's in the college, then he may get infected. There are more complications, hospitalization in adolescent. So there is a need for the long-term protection which can be achieved through available, effective, and well-tolerated hepatitis A. So vaccination is important. Increasing evidence of shift from high to high income group I have already told, especially in the urban areas. So there's a shift. What is more important? We have a group of people who are not immune to this disease and who are more susceptible to the complications and severity. That group we have to protect. Those were the days 10, 15 years back, we need to worry about them because by the child who comes into the school age group or into the adolescent group, early adolescent group is already immune. We are not bothered about that. The prevalence of anti-HIV antibodies, previously I told you 90%, is lower now in adolescents and young adults. Around 80% in Bangladesh and 55% in 5 to 15 years. 90% has come to 50%, 5%. Such is the decrease in the immune level. As a result, HIV is responsible for more acute viral hepatitis predominantly in this age group. Clinical and economic. These two slides were important. Let's see. Again, I'll bother.
Sir,
What
sorry
has
to
happened?
disturb you. Your voice is very breaking. There are a lot of
Hello?
messages there. Sir, hello.
Sir, any issues?
Sir, sorry to disturb you. Your voice is breaking. You are not clear. If you have headphone or earphone, please, if you use it, it will be better because the voice is breaking.
The voice is breaking, huh?
Yeah, yeah.
Okay, sir. I'll just, I've got this one. Otherwise, should I shift to others? Sir, 1 minute, can you give? Dr. Sachin?
Yes, sir.
Able to hear me now?
Yeah, yeah. Yes, now I can hear.
Yeah. You are better audible now.
Also, want I'll shift there. 1 minute if you give me, I'll shift there also.
Yes, sir. Sure.
1 second.
Yeah, you are clear now.
Okay, sir. Okay, sir. Hepatitis A outbreak in the world from 2009 onwards. Just why you have to look into this slide? Because we should also know there has been outbreaks. What are the outbreaks? We think of in terms. India had an outbreak in 2013 in Lucknow, and the route to transmission was E. coli. Then comes India had again in 2014 in Mylapore village. It was a source of infection was contaminated water. Then there was an outbreak in India in Kerala in 2016. 223 people are affected. Eco-oral route, food from newly opened hostel. So see, this is the transmission which has occurred. So still 2016 we had an outbreak. So outbreaks are still there. So there is an importance of disease we have to understand. Now, okay, Dr. Sachin?
Yes, sir. Now it is better.
Okay. There has been a study from the British Pediatric Surveillance Unit. Sir, if it is okay, I'll continue. They have seen that 69 children with viral infection they have seen. Of that, hepatitis A virus was accountable for 39%, hepatitis B virus was 4%, other virus was 23%, and in 33% cases, etiology was not identified. Of the 37 hospitalized HIV cases, 70% had traveled abroad, but only 8% had been vaccinated. See, these children had not taken any vaccines, 8% only vaccinated. So they got it. So you have got a good preventive aspect. So vaccination is important. And we look at the case of viral infection, hepatitis A virus was mostly responsible. So there is a need to understand about this disease, and we have got a good effective vaccines with us, so we can also prevent this. In India, 2/3 of the outbreaks of hepatitis A are. Sir, I'm going to another one if it is here. Two-thirds of the hepatitis outbreaks in India are reported from the rural areas. So we already know the rural areas has been an endemic area. So and major outbreaks have already given, that is 2002 to 2004, it was in rural Maharashtra, Kerala 2004, 2007, Shimla. Hepatitis A, we know the clinical feature, it is a fecal-oral transmission. So whenever you are coming in contact with a direct contact with a person or food and beverages which has been contaminated with the virus, or the cups and spoons which have not been cleaned properly, the virus goes inside, it causes symptoms of nausea, vomiting, and it causes all the debilitation. And as well as sometimes there may be relapsing hepatitis. Clinical features, everyone knows it. Jaundice, dark green dye colored, I'm not going to. Then the pathway. What happens if someone is affected? It resolves in 99% of the cases. That is why everyone is happy we are not bothered with this. But relapse occurs in 3 to 20% of the cases. Because once a disease comes, he gets hepatitis A. He will get hepatitis A, he'll ask, sir, why the disease has come? He'll think that as if we have not treated properly. He'll try thinking in his mind that we have not treated properly. That's why disease has come again. So better to give vaccine and get it properly. The test fatality ratio less than 15 years of age, 0.1% is the fatality. If it is 15 to 29 years of age, 0.3 is the fatality. If it is more than 40 years, 2.1%. So as the age increases, fatality rate increases. If the fatality rate increases, it is not good. So again, understanding that as the age increases, fatality rate increases, severity increases. So we should see that this pattern doesn't occur, should prevent the disease. Fulminant hepatitis is rare, but associated with high mortality as it. There was a seroprevalence study. This showed that the seroprevalence module, the pattern has changed. This is done in the, there's a paper published. Even the seroprevalence data suggests the same for Indian population. Changing epidemiology of hepatitis A virus in India. So age-wise seroprevalence. has happened is that the risk of epidemic, to conclude, India currently has pockets of high endemicity. So both pockets. So within the high endemicity areas, there is risk of hepatitis A exposure, and the risk is remaining more in the older children. And exposure in the low endemic population can lead to again an outbreak. This remains this high endemic, low endemic, both are there in the country. So the risk and the large problem is looming at large. So the global prevalence, if you see what is happening, is that global prevalence of hepatitis A infection has increased by 4.2%. HIV infections are often still limited in children, but can be acutely symptomatic and fatal in adolescents and adults. This again tries to impress upon our mind again and again the importance of the disease. Due to significant socioeconomic status, what has happened? The standard of living has improved, the hygiene has improved. So the HIV is shifting from early childhood to adolescence and adults. So the prevalence of antibodies is less than 15 years, is 5% from 90%. So see, 20% decrease in anti-HIV seropositivity has been noted over 10 years in the last, in children less than 10 years of the last 10 years. Exposure group is 3 to 5-fold increase in incidence of acute viral hepatitis in adolescent age greater than 15 years. Why? The seroprevalence is less. 2-fold increase infections in adolescent age less than 20 years from high socioeconomic status, because they are more, they carry forward with their work with their sanitation, good sanitation. So you see, still, if someone, whatever is the fast food service, is that whatever is the thought of that day, is the fast foods, how much you tell, people like to eat outside, and high social standard, they think that just carrying water after everything will prevent. No, it can be anywhere, as I should find. The source can be, the viral source can be from anything, even the cups and plates which are not washed. So as the need or desire to eat food outside has increased, so vaccination is. So how can I avoid it? Impossible. Then why not I get vaccinated to prevent hepatitis A? So we know everything. So what has the WHO given a paper in 2012? What WHO has recommended that vaccination against HIV integrated into the national immunization schedule for age less than greater than 1 year. It is indicated on the basis of incidence of acute hepatitis A, change in endemicity from high to intermediate, and consideration of the cost effectiveness. So you are spending only around 2,000 rupees, but you are preventing such a fatal disease. If it is a child, though it is 0.3% of fat, what fermented fat failure, but still it is important when it comes to the particular child. Countries with improved socioeconomic status may rapidly move from high to intermediate hepatitis A, so the vaccine is required. In these countries, a relatively large proportion of adult population is susceptible to hepatitis B, and large-scale hepatitis B vaccination is likely to be cost-effective. Therefore, encourage 2,000, not a matter if the child is admitted and spending 20,000 to 30,000. India currently has pockets of high endemicity and low endemicity. There is a risk of hepatitis in older children and adults, and exposure in low endemic population can lead to outbreak. So prevention. But is vaccination hepatitis A effective? It's vaccine work that will be dealt in the next lesson. Thank you.
Thank you very much, sir. Now we will move on to our next speaker, Dr. KP Srikanth, sir.
Dr. Basraj has come. He's the coordinator of this program.
Good afternoon to all, Dr. Ravishankar, Dr. Bhaskar Shinai, Dr. Sachin Patil. It's a good program. So I was supposed to be there because of traveling. I could not pick you. Please carry with that.
Welcome, Basaraja, sir. Thank you.
Thank you, sir. Thank you.
Yeah. Now I would like to request Dr. Naniwadekar, sir, to chair this session.
Yes, I'm already chairing because technical problems they were here. We already introduced Dr. Srikanth KP, and I would ask him to or request him to proceed with the session. Dr. Srikanth, please.
Yeah, hi, good afternoon, and thanks for this invitation, and special thanks to all the Central IAP office bearers and to our HOD Bhaskar sir.
So without wasting much of our time, there was a technical issue. So I mean, I had to change the schedule. So hope things will go fine now. I assume everybody is able to see and hear the audio clearly. There are no issues. So with this permission, I'll move on to the topic. So this is a brief overview of hepatitis A in children, which includes the basic science and also the clinical features and bit of epidemiology. So intestinal health is very important. There is a saying, the good set of bowel is more worthy than any amount of brain. I assume everybody will vouch for this. So coming to hepatitis A, so this is one of the most common viral infections, mainly in the developing world, and it leads to acute hepatitis and acute liver failure. These are the predominant clinical manifestation, and there are some other rarer manifestations as well. So coming to the virology of this virus, so it is a non-enveloped single stranded RNA virus. So this has a bearing on the cleaning and the viral mechanisms outside the body. It belongs to genus RNA virus of the picoRNA viridae family, and there is a single HAV serotype exists, but there can be four HAV genotypes. So this is important. Sometimes, rarely, we can see a repeat infection in an individual. Otherwise, once they acquire infection, the immunity is for very long. So the transmission is mainly from the fecal-oral route by various modalities, like from food, water, and sometimes fomites, etc. So virus can survive in the contaminated media for months, and it is resistant to acid and even temperature up to 60 degrees Celsius for 60 minutes, and in sometimes even freezing environments. Okay, so this I have covered. So prevalence and the epidemiology has been elaborated by previous speaker. So it is predominantly the disease of developing world, the Southeast Asia, the African nation, and also the South American and Middle American nations. So it is predominantly seen in children, but because of the changing epidemiology and immunization, we do see in older children, that is adolescents, and also even in adults. So most of the children, like up to 90%, are infected with this virus within less than 10 years and without any symptoms. So again, this is before the virology, before the vaccination, and things are changing. So and in the later age group, that is adolescent and adults, specifically the high risk group who use injectable drugs or MSM category, and in the high endemicity area, and in certain closed religious groups. Even in developed world, there are larger outbreaks among the destitutes and the other high risk category. And again, the middle income countries are, because once again, poor sanitary condition and poor awareness of the hygienic practices. So this is one of the slides to say how the prevalence is decreasing in United States of America after institution of vaccine. So initially it started in Israel, and after that many of the developing worlds are doing it regularly, and even India has started from previous decade. The things are going fine. So with this, there is a hope that the number of cases will reduce. So now we'll see the transmission. So it is primarily, as I highlighted, fecal-oral route. So once the person ingests the virus contaminated food or water, which can again happen through dirty hands when a person prepares food. So food handlers are one of the important transmitters, and there can be waterborne outbreaks where in crowded urban localities, sometimes the drainage and the drinking water pipes run parallel to one another, and there will be contamination during flooding situation. And rarely it can be because of the various mucosal contacts, like physical contacts. So these are the modalities of transmission. So what happens once the virus enters the body? So once the person ingests the virus reaches the that's intestinal mucosa. It replicates there in the enterocyte, enterocytes, and subsequently it reaches the liver via portal blood. Again, it starts multiplying in the hepatocyte, and the viral progeny is released into bile and reaches the intestine, and it is shed in the feces to continue this cycle again. So this is the first phase, and the patient, the individual will be completely asymptomatic. So he's like a silent carrier and also the transmitter. So majority of the children will remain silent. So that is the problem, like when there is an outbreak or in a daycare center or where a lot of children gather. So we can't really isolate or separate them and prevent the infection. So this is the first stage. So this happens weeks before the onset of symptoms, if at all they develop symptoms. As we know, younger the child, the chances of symptoms are very, very less, that we will see in the subsequent slides. So once in the hepatocyte, so once it enters the liver cell, so the incubation period till the occurrence of symptoms can range from 2 to 4 weeks or more than that. And symptoms can occur within 5 weeks of exposure. Along with this, there will be fecal shedding and also production of the immunoglobulins. We'll see this slide, how this happens. So initially, once the infection happens, then it enters the liver and multiplication happens, subsequently fecal excretion and also the viremia. Along with this, there will be initiation of, there is immune stimulation. So the IgM starts appearing in the blood, and also the hepatitis, clinically significant hepatitis starts happening, which is manifested by jaundice and biochemically by rising ALT. And this is the timeline in which it proceeds. So subsequently, the protective IgG appears. So this can be classified into three clinical categories. Sorry. So the prodrome phase, which is the initial phase where there can be fever, jaundice, vomiting, the non-specific symptoms, and the right upper abdominal pain, which can be very intense, and also the loss of appetite. Loss of appetite is also very intense in this viral infection. So these are the 2 pointers that it could be acute viral hepatitis even before the jaundice happens, that is right upper quadrant pain. So this is because of the stretching of the liver, the Glisson's capsule gets stretched, and that is the reason for triggering of the pain, and loss of appetite. Subsequently, when by the end of this 6th or 7th days, the urine starts becoming high colored, and then the child or the patient enters the icteric phase, where these symptoms do improve, and on the contrary, the child becomes jaundiced, but things starts settling down. The fever, nausea, and vomiting settles down, and the jaundice persists, and subsequently in the convalescent phase, the jaundice decreases further, and everything else improves. So this is how it proceeds clinically in 3 stages. So this is based on the So this is based on the pathophysiological happenings inside the body with relation to the virus. So here adults have more symptoms as compared to children, and generally less than 6 years old usually do not experience notable symptoms, and only 10% develop jaundice. So the younger the child, less is the symptom, and probably they may remain asymptomatic as well. And so hepatitis A sometimes can relapse, that who has recovered can develop another acute episode, and this can also again this will normalize subsequently. So who is at risk? This we have discussed, like those whoever, like any, I mean, in Indian subcontinent, there are pockets of high endemic areas, so there can be repeated transmission, so that we are all at risk in general. So in that, again, those who are having poor sanitary conditions, lack of safe drinking water, a household person with living with the infected person, again this can the transmission can happen much before the person becomes symptomatic. So there'll be like during incubation period itself, the circulation and excretion of the virus happens. And again, for developed countries, if they're traveling to high endemic area, then without being immunized, they are also at risk. A brief about clinical features, as I highlighted, less than 6 years old, majority of them are asymptomatic. Only small, like 10 to 30% develop symptoms who become jaundiced, and usually last for less than 2 weeks. Conjugated hyperbilirubinemia and transaminasemia, the ALT, which is specific for liver, and also AST, both do get elevated, and also bilirubin, conjugated bilirubin gets elevated. So, and this normalizes within like 6 to 12 weeks. More than 6 years, proportionately more number of individuals develop symptoms, that is around 70% from various literature, and they will develop hepatosplenomegaly as well. And it again recovers within 6 to 10 weeks, but it can last very much longer. So we may say that it's a non-specific or a mild infection, complete recovery, but it really cripples the person for at least a couple of weeks. So even though it is a completely recoverable infectious illness, it the daily man-hour working hours are taken out, so there can be a economic burden also in this situation. And coming to the other complication, that is acute liver failure. Small proportion, less than 1% of the cases end up with acute liver failure. In one of the studies, it is, and the fatality rate is around 0.3% in younger children and 0.1% in older individuals. And if there is an underlying liver disease like hepatitis B, C, Wilson autoimmune, so these are the chronic liver illnesses a child can have. So there the chances of failure are more, or there can be decompensation particular to the underlying liver illness. So as a pediatric gastroenterologist, we used to see a more number of acute liver failure, and some of them have even underwent transplantation. It is really disheartening to know that, like, it appears at the outset it is a mild viral infection, but we don't know what are the risk factors for developing acute liver failure, and they will be in a pediatric ICU for a lengthy time with all the manifestations of liver failure, encephalopathy. I mean, they may develop renal failure and pancreatitis also. This is one of the common association what we see along with liver failure. They can continue to have severe pain. From this angle, this is not so mild illness, needs to be taken seriously. Preventive measures should be put in place to prevent all these things. So in addition to this, so there are some extrahepatic manifestations. So all these extrahepatic manifestations stems from the immune activation. So it is a viral infection, it's an RNA virus. So it stimulates the immune system, and in some unfortunate individuals, there'll be aberrant immune mechanism like any other viral infections. So there'll be a lot of inflammatory conditions. So there can be arthralgia in around 14% according to one series. Other includes vasculitis, arthritis, optic myelitis, transverse myelitis, encephalitis, and bone marrow failure. There is something called hepatitis A induced aplastic anemia. We do see rarely, at least in my practice, we see at least 1 to 2 cases in a year, very serious, no standard protocol, and some do recover, some require immunomodulation, and some individuals even require transplant as well in this situation. And in small proportion of individuals, this hepatitis A can trigger autoimmune hepatitis. So these are the immune manifestations. So these are the other things which I have seen in my practice, like in a pediatric gastro practice. So these things can happen. The hemolysis can be very severe, can lead to renal failure as well. Yeah, it is mentioned here, acute kidney injury. So all these extra intestinal manifestation can happen. So again, not to scare anybody, even though it is, we should understand the rule. Younger the child, less chance that child develops symptomatic disease and complicated disease. Older the individual, more likely that symptomatic disease, complicated disease, and extra hepatic manifestations. Okay, so let us see some Indian data now. So this is one of the paper from ILBS. So the burden of disease in India. So they have looked into pediatric individual children who are coming to their center with acute febrile, acute ectopic illness. So among them, nearly half of them tested positive for hepatitis A, that is like acute hepatitis A induced viral hepatitis, and the rest, nearly half, has been excluded because of various, either they are because of some other things or they are indeterminate category. Out of this 50%, majority were just a simple viral hepatitis, just they have jaundice, maybe pain abdomen, vomiting, fever, and things are resolved. So in that, nearly half resolved and half went on to develop some complications like prolonged cholestatic hepatitis, relapsing hepatitis, hemolysis, HLH, renal failure, pancreatitis, various other things, but majority of them have improved. Whereas the small proportion, nearly 20% or nearly 1/10 of all acute hepatitic illness, they presented with acute liver failure, because many other things can also present as liver failure with same manifestation like all other 5 illnesses, sometimes like malaria, leptospira, dengue, all these things can have liver failure in association with their main manifestation. But there are some soft pointers how we differentiate, and as a clinician, as a pediatrician and intensive care specialist, you are all well aware of this, how to differentiate among the various acute febrile illnesses. So in the acute liver failure group, half of them required ICU admission, and again, in half of that, native liver survival with native liver, that is normal recovery has happened, and small proportion died or required liver transplantation. And the third category is which complicates the underlying liver disease, predominantly Wilson and autoimmune liver disease. So they develop some what is called acute on chronic liver failure, ACLF. So this is more problematic than acute liver failure. So the mortality is more than ALF. So they required ICU admission and died. So this is what, in general, what happens. So this is documented in 2019 of the previous decade's experience in ILBS. Maybe more and more data when it comes in, we have more information at how things do happen. So coming to the management, technically we say that it is just a supportive care. So, but this is a lot of misconception around this. So supportive care itself is also a proper treatment in itself. So in this, it includes early detection when the child presents with acute hepatitic illness, just picking up that it is viral hepatitis, that is hepatitis A. So we need to exclude hepatitis E as well. Sometimes that can also present. So we do, once the hepatitis A is negative, we look for hepatitis E. Sometimes in the early phase of the illness, like when you test the serology may be negative, then we tend to repeat it after 3-4 days if the clinical pattern is clearly fitting into viral hepatitis, that is hepatitis A. And subsequently, we may look for other things. So appropriate early detection and appropriate support in the sense of IV fluids, managing all the symptoms and the critical care issues appropriately during the early phase, and also monitoring and development of fulminant liver failure. So this is like development of acute viral induced ALF. So by doing coagulation profile, we can pick up this, and also prevention of spreading to other individuals. So parallelly, if they develop acute liver failure, then we need to manage them in pediatric ICU with all the support, and we have to take care of the encephalopathy and raised ICP. So there is something called jaundice encephalopathy interval. If it is less than 7 days, we label them as hyperacute liver failure. And hepatitis A is also one of the reasons for that. And they have a very good prognosis. The spontaneous native liver survival is very well if we manage their critical care issues in an appropriate way. So the pediatric ICU colleagues do a great job here managing raised ICP and all other aspects, and they come out without anything. If the jaundice encephalopathy interval is more than 7 days, then the chances of native liver goes down. It is not that they don't survive with recover, but there is high chance that they may require transplant. So this one we need to keep in mind. And any child we need to who is diagnosed with hepatitis A, we need to have all these things while handling the child, and also while following up until child completely recovers. Okay, a small proportion of the children undergo liver transplantation for this. maybe in future the things would improve because of the vaccination and other appropriate PICU care. So as such, there is no specific antiviral medication, and there is no dietary restriction required. Maybe this is one of the disease where there is lot of hope from the alternative medicine side. People do believe that things may improve. Maybe since it is a self-recovering illness, they may work as placebo. I have no information. Maybe like we need more studies on that. So this is one of the study from the same group, see how to prognosticate hepatitis A. So this is again hospitalized individual who are sick. So high grade encephalopathy and coagulation profile more than that, and jaundice JE interval, jaundice encephalopathy interval more than 10 days, as I mentioned. So they require the spontaneous liver survival is very less. So they definitely require transplant. That's how we categorize. So this is about the theory aspect and the latest advances, what is happening in hepatitis A. So now we'll see a couple of cases. So this is an 80-year-old girl who presented with jaundice and recurrent vomiting. So jaundice, so child has entered into icteric, the second phase of illness. And prior to that, she had low-grade fever, anorexia, malaise. So there is icterus, hepatomegaly. So these are the presentations. So it's a febrile illness with jaundice, the fever followed by jaundice, and there is hepatomegaly and icterus. So it is an acute hepatitic illness. So most common is a viral hepatitis. So accordingly, it was investigated, and hepatitis A virus IgM came positive. And there will be non-specific like features in ultrasound as well. So when we do ultrasonography, so because see, a child has jaundice, fever, and vomiting. So one is definitely it is acute hepatitis. So other than that, see, when there is a right upper quadrant symptoms with fever, so we do think of other etiology, non-infectious etiology also. There can be cholecystitis, gallstone-induced cholecystitis, other manifestations can happen. So as a clinician, one of the differential strong contender will be hepatitis A, but we need to look for other things also. So accordingly, the hepatitis USG will also be done. So there will be edema around the biliary tract. So this is called periportal cuffing. So we can see around the portal tract throughout the liver, we can see edema which appears as cuff. So parallel to that, there will be GB wall edema. So this is again a very strong indicator that it is a viral hepatitis A induced. So this is again labeled as diagnosed as acute hepatitis A, and management was done accordingly, and child recovered completely. So this is another child. So you can see it's 8-year-old. Here is a 10-year-old boy, slightly older. And we need to keep in mind, older the child, the chances of having symptoms, complications increases. So here child is jaundiced, vomiting, and there is excessive sleepiness. So this is, there is a component of encephalopathy, or there will be reversal of wakeful and sleepiness cycle. Prior to that, he had that prodromal symptoms. He is constipated as well. On examination, there is icterus, mild hepatomegaly, and grade 2 encephalopathy. But rest of the things are normal, except for flapping tremors. There are no signs of raised ICP so far. So on examination, there is conjugate hyperbilirubinemia, transaminasemia, and there is albumin on the lower side, and there is coagulopathy. This we label it after giving 2 doses of vitamin K. 6 hours apart, and vitamin the INR done 6 hours after the previous dose. So because sometimes the correctable vitamin K deficiency related coagulation abnormality can mimic, so that we don't label it as ALF. So this here the child hepatitis A serology was positive. Rest of the features were there. So it is a ALF due to have A with encephalopathy. Again, this child improved with the supportive care, probably proper PICU care, and the jaundice encephalopathy interval was also short. So this is a spontaneous liver survival. So we'll go to case 3. This is 12-year-old, same acute hepatic illness with encephalopathy, and now here there is altered sensorium as well. So grade 3 hepatic encephalopathy, pupils are dilated. So here raised ICP features are there: hypertension, brisk reflexes, upgoing plantars. Again, the lab parameters showed coagulation abnormality, transaminasemia, serology positive, and there is mild hyponatremia as well, which can happen as a part of acute liver failure or liver involvement. And this child had grade 3 encephalopathy with raised ICP. So child was started on supportive management. So here salvaging the brain from cerebral edema and complications is very important. So that is one of the key determining factor for the safe survival of the child during that phase. So proper ICP monitoring and measurement helps in recovery, and these children should be always managed in a transplant center. So, and we prepare them for transplant, keep the donor ready. So and it is a very controversial area regarding when exactly to transplant, but when we have those criteria, 3 criteria which I previously discussed, they require transplant. Okay, so this is about the 3 cases about the complication, and this is the last case. Probably after that we will just have a quick recap, and we will close this topic. So 6-year-old girl, acute hepatitis, otherwise fine, continued to have pruritus subsequently. So it is a hepatitis A with prolonged cholestasis. So there are some risk factors, like this child has sickle cell trait, and that is background hemolysis going on, and managed with UDCA and cholestyramine. So UDCA is it's a synthetic bile, ursodeoxycholic acid, which is a hydrophilic component which increases the bile flow. Out of topic. So this is from the bear urso. It is initially from bear liver they used to take and prepare. Now the synthetic things are available, and traditionally it came from China earlier. Okay, and this is one of the most common drug we use in hepatology practice, because it is liver protective. It improves the bile flow. Same child was managed with that, and child recovered. So when there is underlying hemolysis, when the biliary apparatus is overloaded, there can be cholestasis. So this is one of the long-term, one of the complications. So why this happens? There will be a lot of antibodies produced against this virus. So there can be molecular mimicry, and there will be antibodies against the bile excretory proteins. So there will be the bile salts are not excreted. So that's why they get accumulated and they lead to cholestasis, and gradually it's a recoverable one. And in the same breath, so this is the very mechanism why they develop autoimmune hepatitis as well, small proportion. Again, antibodies against various components, proteins in the hepatocytes. So it is a molecular mimicry kind of thing. Okay. So with this, we'll close this session. A quick recap. So hepatitis A it's an inflammatory condition of the liver. It is transmitted through fecal-oral route and through direct route as well, direct contact as well with the infectious person. So there is a guideline regarding how to isolate the person as well when somebody is infected at home, and when there are high-risk individuals like pregnant women or who is at high risk. So most recover with lifelong immunity. Small proportion could die because of all the complication which we have discussed. And prevention is always better than the cure. Now the interesting observation is that, like with the advent of agriculture revolution, we brought in infectious diseases, and with the advent of industrial revolution, we brought all other diseases, including malignancy, the other 2 category. So again, and thought that the infectious diseases have gone with antibiotics and vaccines, but that is not true. Population of India has doubled. So as of today, as I speak here, it is 1.4 billion. 40 years back, it was 0.7 million or 1.170 crore. It has doubled. So definitely there is overcrowding, and there is more risk of infectious disease than ever before. So we need to really be cautious about all the things and follow all the guidelines regarding the prevention of these diseases. So again, it is safe water and better sanitary conditions can help us prevent this. Okay, and the vaccine is available and it is being given now universally. So hope that in future these things will come down. Okay, with this I end my talk, and I thank you for your attendance and patience listening. Thank you.
Thank you, Dr. Srikanth. It was a very nice talk. and just covered the entire part of the hepatitis A. Are we allowed to ask the questions? Because I've got one question from
Yeah,
my
yeah,
side.
please, sir. Please. Yes, yes, yes.
Because it is better that we finish off the questions here itself.
Yeah,
There's
yeah.
one question from my side, Dr. Srikanth, and one
Yes.
just come from the audience. The question from my side is, now we are catering right now, we are discussing this scenario with a bead, which is a small branch, and I mean, uh, they have got the facilities may be available, may not be available. Will you recommend to investigate each and every case of hepatitis, which is obviously a garden variety of hepatitis A, to go for IgM, HAV, and HEVs, or will you just investigate in terms of SGOT-PT just to monitor the severity of the illness? What would be your recommendation for that?
Sir, yeah, I mean, like given the cost benefit of thing, yes, but to confirm hepatitis A, we need to do HAV IgM. Okay, and it has to be done like not very early, at least when the jaundice symptoms appears, at least at that time, not when there is just fever, anorexia, upper abdominal pain. When we do all the viral, we do tests for acute febrile illnesses. When we invest, not at that time, it may not come positive, and small proportion may test negative. Otherwise, yes, it has to be done. Only then we can confirm that it is acute hepatitis A related thing. Now, what happens if we don't do? So if the child recovers, so it is well and good, no problem. But if child doesn't recover, if the child continues to have jaundice, if child deteriorates, if child develops encephalopathy or the bilirubin worsens, then again at that point we are forced to do all the tests. According to the standard hepatitis evaluation, yes, you have to do hepatitis E. And we know that the confirmation is also important, maybe for future prognostication and proper documentation it is required. Again, it depends on the local practice, the availability, and the financial situation and all those things. Those things do matter.
Yes, because if I see some 10 patients or 15 children who have come from the same locality with the same complaint, then probably I'm sure that we are dealing with some hepatitis virus outbreak, which majority of them should show recovery on its own.
Yeah.
And the rest of the times, in case this is going into a problem, then we should investigate.
Yeah.
The other two questions which have been asked is question in your case scenario 3. Somebody, Dr. Mungekar has asked, why is it that 3% saline was used? I think it is used for the raised ICP.
Yes, it is for raised ICP. So I mean, like, yes. So right now, I'm not an expert on this area, but so earlier we used to manage children with raised ICP in PICU. Now PICU specialists do take care of that. So there are various modalities to handle that. Like, yes, 3% saline. I don't remember the dose exactly. It's a continuous infusion so that we maintain the sodium levels between 145 to 155 milliequivalents. That is the thing. So I stand here for corrected if I'm wrong. So that is the thing.
That's correct. Basically, to for raised ICP.
Yeah.
So there are a couple of questions. Once again, one more question which comes up. Gone are the days when we as PG students were using the typical the neomycin capsules to sterilize the gut. That's what the practice which was then there. With absence or non-availability of this neomycin, is it necessary that every time in a hepatic encephalopathy you have to sterilize the gut by using some other antibiotic, or it's not a must? What is your take?
No, it is not a must. It is not a must. So the hepatic encephalopathy management is it remains general. So there is no specific for hepatitis A. So 2 to 3 soft loose stools that has to be maintained. So that is one of the preventive aspect in regards to worsening of the encephalopathy. So we use so as such for acute hepatitis, there is no, if you look at the exact literature and evidence, even lactulose is not proven. The rifaximin which we use is not proven for acute hepatitis, the acute liver failure related encephalopathy. There is something called chronic liver disease, that is ACLF or cirrhosis related encephalopathy. There these things work, but we probably borrow and we tend to do all the things rather than feel sorry later on. So we do that.
Yes.
But if you see the guidelines, so it is not recommended. But to be frank, I do use that. We do use in our practice also when an ALF child is there. We do put them on these two things with the hope that that will improve. And there are no studies from India. I mean, this is one of the paper from Dr. Anil Dhawan group, who is an Indian and but is in they're from King's College. Yeah, they have done this analysis.
Yeah, okay. And just a couple of quick questions. One, Dr. Ramakant Patil, our EB member, has asked when to suspect underlying chronic liver disease and how to investigate. Basically, any child who has come to you is an acute onset patient. But where do we suspect that this child also might have a long-standing chronic liver disorder? So is there any way in which we can identify this?
Yeah. So one is history, like any previous jaundice episode. So whenever we take when we get the history of jaundice, the first next question is like, was there any similar illness? Whether it is a repeated relapse of the jaundice or repeated attacks. So that's one thing. Second thing, like non-specific pointers like growth failure and all those things, which can happen otherwise also in India. Malnutrition is like one of the major problems. And the important clue what we get is from the ultrasonography showing altered hepatic echo texture. So this is one of the specific things. If a good radiologist with keen interest does that, so we do see this as against the periportal cuffing. So when we see hepatic echo texture is altered, there is irregularity. So then definitely it says that there is underlying chronicity. Otherwise, it is very difficult to differentiate. Only the course of illness will tell.
Okay, thank you. And now there are multiple questions which are there in the chat box, but I think we will be eating too much of time of the next speaker.
So quickly, I'll finish this question. So what is the reason for relapse? So as I said, there can be four genotypes. So that will code for like a single, like serotype, the protein thing will be single. But probably this is the reason. Even I am not very clear. There is no clear mention of this. Very rarely, as I said, we see repeat of same thing. But that could be because of maybe very rarely four genes, maybe recombination, different viral that protein epitopes and no immunity for that a different virus. Maybe that could be the reason.
That could be the reason. Yes. Thank you very much. I think I will request you to answer. There are a few questions more there in the chat box, but I would not like the future speakers' time be eaten up. So thank you very much. Thank you.
Welcome, sir. Thank you, sir. Thank you. Bye.
Over to you, the organizers.
Yeah. Thank you very much, sir. Srikant sir, Naniwadekar sir, it has been great to hear. I think most of the doubts are also cleared, and we will have some doubts for the next speaker who will be dealing with the diagnosis, management, and complications and prevention of the hepatitis. I would request Dr. Rinjin Srivastava ma'am to start her lecture, and I would request Dr. Ramakant Patil sir, who is a EB member. Welcome, Ramakant sir. And I would like you to introduce Dr. Rinjin ma'am. Before that, I would request, I would like to welcome Dr. Shailesh Vaidya sir, who is a MMC observer. This session of hepatitis A module has been MMC accredited for 1 point. I would like Vaidya sir to have a word. Shailesh Vaidya sir. I think he is not. Vaidya sir. Okay, we will start the session and we'll see. We will request him to have a word after this lecture.
Thank you, Dr. Sachin. At the outset, I'd like to thank Central IAP, BEAD IAP, and IMA for giving me this opportunity to interact with you all on this virtual platform. So my job is to discuss the diagnosis and management of hepatitis A along with management of acute liver failure. So hepatitis A, as was being discussed by the previous speaker, is one of the most commonly reported vaccine preventable diseases. And it presents non-specifically with one or more than one of the following symptoms. They can have fever, malaise, anorexia, vomiting, nausea, abdominal pain. Icterus may or may not be there in smaller children. But one thing is very commonly seen, that is marked elevation in serum aminotransferases. They may not be rise in bilirubin to a higher level, but serum enzymes are, liver enzymes are definitely raised. Younger children may or may not have typical symptoms. And most of the HIV infection is self-limited. Most of the times it resolves on its own, and it does not lead to any chronic liver disease like in case of hepatitis B and hepatitis C. So hepatitis A does not lead to chronic liver disease. Now, how do we diagnose hepatitis A, as was being asked by one of the audience as well? So the first thing, the patient presents to you and you suspect that the child might be having any of the acute viral hepatitis, you need to confirm by doing the liver function test, which should include total serum bilirubin and the fractionated serum bilirubin. So usually in hepatitis A, the total serum bilirubin is around 10 milligram percent. If it is more than 15, 20 milligram percent, then you can suspect some underlying hemolysis as well. And then you'll have to investigate further. The SGOT, SGPT are typically 4 to 100 times upper limit of the normal. If you take the normal as around 30 to 40, then there are only 3 conditions where this high, around 300 to 1000 or 2000 levels can be seen. So one is acute viral hepatitis. Another is toxic condition like drug-induced, mostly paracetamol-induced, or ischemic injury to the liver enzymes. So liver. So if there are very high transaminases, then you have to rule one of these 3. That is acute viral hepatitis. Secondly, toxic injury because of any drug, or ischemic injury. Now, the third and very important investigation is the prothrombin time and INR, international normalized ratio. This is not for the diagnosis of hepatitis A, but this is just to prognosticate the situation, whether the child is landing into liver failure or not. And along with this, we should also do serum proteins, which will give you a clue whether there is any underlying chronic liver disease or not. There was one question also, how to differentiate whether there is any chronic liver disease or not. So these are the investigation, first line investigation, which you should do to confirm that there is acute viral hepatitis. Now, for the etiology, most commonly we see in less than 12 years of age, most common culprit is hepatitis A, and around 10 to 12 years and more than 12 years, you can have hepatitis E as well. So for the diagnosis of hepatitis A, yes, anti-HIV IgM has to be done, which is the gold standard. If you have not done, you cannot be very sure. In a community also, if there is an outbreak, then if you have done few of them sampling you have done, then you can omit most of them. But most of the times you will have to do HIV IgM. Now, this is the gold standard. And as Dr. Shrikant was saying, that in the initial 5 to 10 days, it remains negative. So if you get it done in the initial febrile period or initial 10 days, then it might come negative. So if you are strongly suspecting, you can get it done repeated after in the second week of illness as well. Now, this persists for up to 4 months, and there could be false negative, as I said, in the early phases of the disease, and can be false positive also if the child has been recently vaccinated. So this you have to see in the background of the clinical presentation. The sensitivity and specificity is more than 95%. If there is IgM, hepatitis A is there, IgM, HIV in second week of illness will be positive. Anti-HIV IgG is not specific for the diagnosis, but it only demonstrates that there was a past infection or post-vaccination status. It rises, but it later, but it persists for a longer time. So this does not give us any diagnostic evaluation, only HIV IgM does. Another test for the diagnosis is HIV RNA in the stool. This is not usually done. Mostly is done for the research purpose, or in some cases when you want to diagnose the relapse of the hepatitis A, then you can utilize this, which is not generally needed. So main thing which we need to do is anti-HIV IgM if you are suspecting acute viral hepatitis to diagnose whether this is due to hepatitis A or not. Ultrasonography per se is not required for the diagnosis of hepatitis A, but if you are suspecting a chronic liver disease, like on history, if there is a pruritus or there a history of recurrent jaundice or growth retardation is there, or on examination you find that the liver is firm, hard, very large liver is there, splenomegaly is there, ascites is there. So in such cases, you can go for ultrasonography to diagnose other conditions or if there is any atypical presentation of hepatitis A. In hepatitis A, you will find only hepatomegaly, splenomegaly. Now, this splenomegaly is the criteria for splenomegaly radiologically is different from what we get on palpation. In a radiological, they can report splenomegaly, but you won't be able to at times palpate the spleen. Gallbladder wall is thickened, there might be sludge or contractor gallbladder might be there, lymph node in portohepatic lymph nodes may be enlarged, and periportal cuffing. All these changes might be reported in acute hepatitis A. In case of chronic liver disease, there would be other changes like in altered ecotexture, and sometimes they can be because of portal hypertension, collateral vessels can also be seen. So for the diagnosis of hepatitis A, it is not required, but if you are suspecting any chronic liver disease or if you think that there is some atypical presentation, then you can go for the ultrasonography. Now, as far as management is concerned, there is no specific management for hepatitis A. It is most of the time supportive only. Adequate hydration is required as per the status. Nutrition supports to be given. There is no need to restrict diet. There is no need to restrict oil or protein or give high amount of sugar. Antiemetics can be utilized if there is severe vomiting or if there is nausea, then proton pump inhibitors can be given. If high fever is there, then antibiotics, paracetamol plain can be used, and cholinergic agents like ursodeoxycholic acid can be used if there is associated pruritus or if the serum bilirubin is more than 15 to 20. We have to monitor international normalized ratio. So for every patient with the first investigation along with LFT, INR should be done so that you can classify the patient whether the child is in failure or not. I'll come to the definition later on. And hospitalization of a child is not required unless and until the child is going into failure, which will be decided by the INR. If the child is having severe vomiting, which is not getting controlled by oral antiemetics, then also you can get a child admitted. But in acute hepatitis A, generally this situation is not seen. If the child is having severe vomiting, then there might be some other conditions as well. So then you have to investigate further and then act accordingly. One thing is very important in case of management of hepatitis A, that all the patients who were not admitted, all the patients should be called for follow-up after 1 to 2 months post-illness and with LFT. So normally after 1 to 2 months post-illness, the liver function test normalizes. If it has not normalized, then you have to investigate for some underlying chronic liver disease. So sometimes it can also happen that the symptomatically the child has not improved, but biochemically the child is improved. Like one case was also there, like in cholestasis, prolonged cholestasis is there, child is having pruritus, but biochemical improvement is there. So in that case also you can reassure the parents that is going to improve, unless you find that there is a change in INR or there are other there is pallor or other atypical features are there. You don't need to further investigate the child. So ask the child to come after 1 to 2 months of post illness with LFT, and if it has normalized, there is no need to do anything further. But if it is not normalized, then you need to investigate for some underlying chronic liver disease. Complications of hepatitis A, one is relapse is seen. Persistent cholestasis can be seen and acute liver failure. And rarely vascular, other systemic involvement can be there like vasculitis, arthritis, thrombocytopenia, pancreatitis, and other system involvement. So relapse of acute hepatitis A is when a child has hepatitis A, the disease resolves biochemically and clinically, and again the child has typical clinical and biochemical features of HIV. Now this situation is very difficult to diagnose with HIV IgM because the previous site is going to remain there for 3 to 4 months. So if the child presents with typical symptoms and if you go for HIV IgM, then it is going to be positive. So you may not be sure whether this is because of the previous rise or this is a new rise. So in that case, diagnosis can be done by PCR of serum or feces. Most of the time it is not required because if the child is presenting clinically with such features, then you have to give supportive treatment. And after that, the child improves also. The prevalence of relapse is different in different studies, ranges from 1.5 to 20% of hepatitis A patient. And the pathophysiology is not very clear, but in different theories are there. One is presence of different serotypes. Second is there was incomplete elimination of HIV in the previous episodes. And then there's resurgence of the infection. And some immunogenic mechanism have also been implicated in this. The treatment remains general support and monitoring as was with the first episode of the hepatitis A. Second complication is prolonged cholestasis. Very rarely seen in children, but yes, it is seen. It is not uncommon. The child would present with conjugated hyperbilirubinemia. Peak serum bilirubin it goes for more than 10, and this lasts for more than 12 weeks. Now, the serum transaminases level won't rise in this case. Once the rise had happened, there is no re-rise in the serum transaminases. So you can be sure that this is prolonged cholestasis. Child has extreme pruritus. Most of the time, it goes by cholinergic agent like UDCA. Sometimes steroids and other agents can also be used. So along with UDCA, cholestyramine can be used if there is severe pruritus, and you can give a trial for 4 weeks. If the child is not improving, then you can further add rifampicin, naltrexone, ondansetron, etc. Serially after waiting for 4 weeks in between. So acute liver failure is a condition, and there was a pediatric acute liver failure group which has given a definition of acute liver failure in pediatric age group. So one is their criteria that there should not be any evidence of chronic liver disease, because if there is any chronic liver disease underlying, then this will not be labeled as acute liver failure. This will label either as chronic liver failure or acute on chronic liver failure, depending on the etiology of the acute part. So there should not, for the criteria for acute liver failure is that there should not be any underlying chronic liver disease. Second, the biochemical evidence of liver injury should be seen within 8 weeks of the symptom. And third is coagulopathy. Uncorrected coagulopathy. So how do we define uncorrected coagulopathy? Whenever a child comes to you in your OPD, you get INR done and it is more than 1.5. Then the first thing you have to do is give a shot of vitamin K 5 milligram and repeat INR after 6 to 8 hours. If after 6 to 8 hours, the INR still remains more than 1.5 and the child is also having hepatic encephalopathy along with that, then he is labeled as acute liver failure. Or if the child has INR more than 2 after giving 6 to 8 hours of vitamin K, but does not have encephalopathy, still the child will be labeled as acute liver failure. So corrected INR more than 1.5 with encephalopathy or more than 2 without encephalopathy. So this is the point when the child will need admission and further monitoring. So the etiology of acute liver failure in children is the most common cause is acute viral hepatitis, and out of this in Asia, hepatitis A is the most common cause of acute liver failure in Asia. So this is not a mild disease. At times it can land up into liver failure. So we have to be very, very observant in a patient with hepatitis A, and we have to monitor the child very closely until remission. Other causes of acute liver failure are most of the times indeterminate. We don't come to know what was the cause. Metabolic liver disease, Wilson disease in older children, in younger children, galactosemia, tyrosinemia. These are the causes. Drug-induced liver illness, like most commonly paracetamol or ayurvedic medicines, are the ones which can be which can cause acute liver failure. autoimmune hepatitis, and herpes simplex virus. These are the other causes for acute liver failure. So in a child with acute liver failure, we need to investigate for all of these things. Now, the mortality of acute liver failure in pediatric age group is almost 25 to 50%. So most of the time they recover, but yeah, there are times when they don't recover, and we need to send them for liver transplantation. Now, this is a study done in ILBS Delhi, ILBS Delhi, and they found that the most common cause of in acute liver failure in pediatric age group was viral hepatitis, and that was acute hepatitis A virus infection. Not all of them presented with encephalopathy. Like in this study, almost 80 to 90% had encephalopathy. In some study, they have shown that only 50% had encephalopathy. So rest of the children, almost 50 to 20 to 50% of children may not have encephalopathy, but they can have acute liver failure, and they have poor outcome if there are some scores like pediatric end-stage liver disease score. If that is higher, then they can have poor outcome. If the interval from jaundice to encephalopathy is more than 7 days, then also they can have poor outcome. So with this study, they found that hepatitis A is the most common cause of acute liver failure in pediatric age group in India. So how do you evaluate such children? So first thing is, as is true with any disease, we have to have a very comprehensive history, a detailed history. The aim of this history taking is to identify the etiology and the severity, whether the child needs admission or not, or whether we can treat the child on OBD basis. So we have to find whether what is the time of onset of symptoms, what is the mental status, whether there is viral hepatitis or not. As Dr. Srikanth was discussing, there are 3 phases. In the initial prodrome phase, the child will have fever, malaise, and non-specific symptoms, and then the child will shift to icteric phase. When the child shifts to icteric phase, that is the onset of jaundice, all these non-specific symptoms and fever subsides. If the fever is still persisting in the icteric phase, then you can have other etiologies like other non-hepatotropic viruses like varicella or cytomegalovirus, etc. So then you have to think in that direction as well. Now, history of blood transfusion could be there. This could be other cause of hepatitis B, acute hepatitis B could be there. Use of any hepatotoxic medication, and specifically paracetamol. Now, recently I had dealt with one patient. The child was 10 months old, weight was 9 kg. The child was prescribed syrup paracetamol, half teaspoon. The mother was illiterate. She already had paracetamol 250 milligram strength, and for her elder child, and she gave half teaspoon of 250 milligram. When we measured her half teaspoon, that came to be 5 ml. So she was administering 5 ml, that is 250 milligram, every 4 to 6 hours of paracetamol. And along with that, her elder son was sometime advised by somebody that to give half of the crocin tablet, that is 250 milligram of crocin tablet. So, since the fever was not going down, she added that tablet also. So a child of 10 months old child with 9 kg who should be given around 60 milligram per day, she was administering almost 250 to 300 milligram per day. And the child landed up into acute liver failure. So it's very important. One thing is very important, that whenever we prescribe paracetamol, strict instructions should be given how much and when to be given. And secondly, if a child comes to you with a history of fever, with acute liver failure, you should clearly ask whether there was some intoxication of paracetamol or not. Luckily, the child recovered with N-acetylcysteine and child is doing fine. So along with this history, we have to ask the history of family history of Wilson disease, infectious hepatitis, autoimmune hepatitis, etc. to rule out any underlying chronic liver disease. Pruritus, ascites, growth retardation, all these things are pointers towards chronic liver disease. So in examination, the main aim is to assess the growth and nutrition of the child and any complication of associated liver disease. So growth, evidence of coagulopathy is there or not, any bleeding tendency is there or not. We have to look very carefully about the liver surface, liver margin, because most of the time you come to know that whether there is underlying chronic liver disease or not. If the liver is small size, like even in hepatitis A, the liver will be enlarged, but it will be 1 to 2 centimeter in length and it will be soft to touch. But in case if there is underlying chronic liver disease, then it will be more than 2 centimeter. It will be firm to touch. The margins will be leafy. Left lobe of the liver will be enlarged. So all these things you need to take into consideration while you examine the child. And you have to assess the central nervous system also, whether the child has landed up into hepatic encephalopathy or not, and features of portal hypertension are not there or not, ascites, splenomegaly. And if required, if you are suspecting the child may have Wilson disease, then you can go for the test for K-ring, assessment of K-ring also. So for the laboratory investigation of acute liver failure, the main aim is to assess the degree of inflammation, injury, and function of the liver, and to guide transplant decision. So the first thing is you have to go for complete liver function test. Coagulogram has to be done. Complete blood count has to be done. Serum ammonia, renal function has to be done. And if you're suspecting any other disease like Wilson disease or autoimmune hepatitis, then you have to do investigation in that direction. Now, a specific investigation, like as I said, if there is persistence of fever in the icteric phase as well, then you have to go for other hepatotropic viruses like cytomegalovirus, Epstein virus, all these things you have to look for. Wilson disease, if you are suspecting, the most common chronic liver disease in children more than 3 years of age is Wilson disease. And this is treatable condition. So you should rule out if you are suspecting any chronic liver disease. So serum ceruloplasmin, 24 hours unit copper estimation, K-ring estimation should be done. Autoimmune hepatitis is another treatable condition, and we should not miss. So if you are suspecting chronic liver disease, at least Wilson and autoimmune hepatitis, these two things should be investigated thoroughly. In rare cases, hemophagocytosis can be there, or drug overdose can be there, which you have to you can find out on the basis of history. So for the treatment is supportive in case of acute liver failure. A central venous line should be inserted. Volume resuscitation should be done. If required, vasoactive drugs should be given. If sedation is required, or if their child is conversion, then propofol can be given. Anacetyl cysteine infusion should be given. Anacetyl cysteine is a drug which is restores the glutathione store of the hepatocytes and helps in hemodynamic stabilization and improves the oxygenation of the hepatocytes and heals the hepatocytes in a way. So though it is controversial, but there have been reports which have shown that there are survival benefits of anacetyl cysteine. In West, if you go, then they don't use anacetyl cysteine because they have better facilities for transplantation. So if they are suspecting a child who might need transplant, the child is immediately shifted to the transplant center and then managed accordingly. If the child needs transplant, then the child is transplanted. But the setup is different in our case. We may not have, because of various regions, transplant available because of financial constraint and because of the transport facility. Many times transplantation is not possible. So in that case, our only rescue is anacetyl cysteine, and there have been many studies in which it has been proven to be beneficial. So proton pump inhibitors can be there. And as somebody was asking whether all these liver tonics should be given or not, no, none of the liver tonics have been studied thoroughly in children, and they are not recommended for the use in pediatric population, like Lola, L-ornithine, L-aspartate, even lactulose and other non-absorbable antibiotics, rifampicin, neomycin, etc. They are not beneficial in pediatric acute liver failure. But child should be monitored very thoroughly, very, very closely. Vital signs should be monitored, neurological status should be monitored, and liver span should be monitored. And whether the child is landing up into cerebral edema or intracranial hemorrhage or not, urine output, bowel habits, electrolytes, all strict PIC monitoring, which we do, it should be done in case of acute liver failure. If the child is having hepatic encephalopathy, then we have to treat that. And the main aim for the treatment is to reduce the risk of cerebral edema and intracranial hemorrhage. So the child should be kept in a minimally stimulated environment, the elevation of the head, sorry, for the drainage of the CSF, and close monitoring should be done. unnecessary intervention should be avoided. But if the child requires, then endotracheal intubation can be done. Fever and shivering, all these should be prevented, so that because that can lead to raised intracranial pressure. And sometimes if we don't have a transplant facility, then we can have continuous renal replacement therapy as well for the treatment. Raised intracranial pressure and cerebral edema can be treated with 3% saline infusion. So 1 to 2 ml per kg of 3% saline infusion is given as bolus over 10 minutes slowly, and that can be repeated. The main aim is to keep the sodium between 145 to 155. Nowadays, 3% saline is not available, so the 9% saline, 0.9% saline is restructured into 3% saline by some addition and deletion of the saline. And if there are obvious neurological signs, then mannitol also can be used. And though hyperventilation is not advised in case of raised intracranial pressure, but in cases where the PCOT is less than 35 millimeters of mercury and mannitol also has not worked, then in these situation you might go for hyperventilation. Hypothermia, prophylactic phenytoin or corticosteroids have shown no proven role in pediatric population. So electrolyte disturbances are there that should be dealt accordingly. The child may land up into acute respiratory distress syndrome and respiratory failure that has to be managed. The child can have hypertension because of peripheral vasodilatation. So in that case, vasoconstrictors can be used. Coagulopathy, as I said, that in the initial phase, if the child presents with deranged INR, then 5 to 10 milligram of vitamin K should be given. And there's no role of FFP replacement unless you are going to perform any procedure on the child. And all these things, triprecipitate and recombinant factor 8, they are later required if the child is not at all improving with vitamin K. Platelet transfusion again is not indicated unless there is significant bleeding. So the only rescue remains vitamin K. That too should not be given for more than 3 to 5 days. Sepsis is a major cause of death most of the times, and if the child lands up into sepsis, then we have to find out the causative organism by cultural sensitivity and then treat accordingly and use the appropriate antibiotic. Acute kidney injury can require renal replacement therapy or peritoneal dialysis at times. And last rescue is liver transplantation, which is decided on the basis of there are 2 scores: King's College Hospital criteria and pediatric end-stage liver disease. In pediatric population, there's no fixed score, which score should be used. There are different centers use different scores and act accordingly. But for a general pediatrician, if the INR is reaching up to 4, then you should start counseling for liver transplantation, and if possible, shift the child to liver transplant center. After that, the child might deteriorate or might get well also. So that will depend on the medication given over there. And if the child deteriorates and they're ready for transplant, the transplantation can be done. So you should be watchful whether the INR is reaching 4 or not. If it is less than 4, you can manage with N-acetylcysteine and start preparing the family for transplantation. So in hepatitis A, if there is deterioration in the clinical condition and no improvement with the supportive treatment, or there is grade 3 to 4 encephalopathy without any improvement, then transplantation can be thought of. So this is the King's College Hospital criteria. It is not specific for HAV, it is for all of them. And it will depend on which center you are referring. They'll use their own criteria. So we'll see a few of the cases. This is a 7-year-old boy who presented with fever, anorexia, nausea, and altered sleep cycle, typical features of hepatitis. On examination, there was icterus, mild splenomegaly. There was no ascites, but grade 1 hepatic encephalopathy was there, which on history we can find that there was altered sleep cycle. He was managed outside and referred with polar color urine and oliguria. So some amount of hemolysis was there and renal involvement was there. On investigation, bilirubin was 8, direct was 5.6, SGOT-PT was high, albumin was okay, 3.4, but INR was 2.3. And IgM HAV was positive, hemoglobin was 5, very low, and rest of the things are normal, but he was G6PD deficient. and EOG was showing gallbladder edema. So this was a case of acute hepatitis A with G6PD deficiency induced hemolysis. So since we have seen that there was atypical features of colocare urine and oliguria, and then hemoglobin also was 5. So this indicates that there is some underlying hemolysis going on, and then in that case you have to work up for G6PD as well as Wilson also. Wilson also can lead to hemolysis. In second case, there is a 9-year-old girl with jaundice, vomiting and anorexia. Typical features on examination, there was icterus, mild hepatomegaly, no encephalopathy was there. Bilirubin was 6 and SGOT-PT was very high, INR was normal, and HAV IgM was positive, and gallbladder edema was there. She was given supportive management. There was no dietary restriction, and on discharge. On follow-up, when the child came, she had pallor and petechiae all over the body with fever. And on further investigation, again, in this child also, the hemoglobin was 4.6, reti count was corrected reti count was 0.4, and yes. So finally, the child, we had to do a bone marrow examination and found that there were hypocellular marrow, which were replaced by fat species. So in this case, it was aplastic anemia associated with hepatitis A. She was managed conservatively with transfusions along with antibiotics, and then later on, as per the advice by the pediatric hematologist, she was given cyclosporin, and she recovered after 4 weeks. So we should always look for the atypical features in case of hepatitis A. Now, in this case, the child was 8-year-old girl who came with jaundice and ascites. There was no encephalopathy. On examination, there was again pallor, icterus, firm hepatomegaly was there with splenomegaly. Now, with firm hepatomegaly and splenomegaly, you should think of some underlying chronic liver disease. Now, child was investigated, reti count was very high. Again, some hemolysis was going on, and the child was investigated for Wilson disease, and there was low ceruloplasmin, high urine copper, and KF ring was present. So the child had Wilson disease. So in this case, you can, as I was talking, that if there is any underlying chronic liver disease, then the diagnosis becomes acute on chronic liver failure. The chronic part is Wilson disease, and since the child is having acute liver failure, so the term is called acute on chronic liver failure, because this was, though hepatitis A was there, but there was underlying chronic liver disease also, and that at times gets aggravated because of the injury to the hepatocytes because of acute infection. So this child was put on deep histamine and zinc and pyridoxine, and is on regular follow-up. So the prognosis for patient with pediatric patient with acute liver failure is that it is poor survival. More than 50% of children only survive. Better prognosis is seen with hepatitis A and acetaminophen overdose, and poor prognosis is seen with other drug-induced liver injuries, hepatitis B, and indeterminate cases. So the prevention is, yes, vaccination is one of the preventable strategies, but along with that, we have to improve sanitation, food safety should be taken care of. Hepatitis A is inactivated by high temperature chlorine and formalin. So places where clean water is not available, you can advise them to boil the water and then drink those boiled water. And the spread of hepatitis A can be reduced by adequate supply of safe water, proper disposal of sewage, personal hygiene, and hepatitis A vaccine. So to end, most of the HIV infection is self-limiting, but all patients with acute viral hepatitis A should be followed up for normalization of the liver enzymes, because we don't want to miss any underlying chronic liver disease. HIV should not be taken very lightly, though it is self-limiting, but it's the most common cause of acute liver failure in children in Asia. So that these children should be monitored very closely. And patients of ALF should be referred to liver transplantation as soon as possible. As soon as the INR is reaching 4, you should start preparing the family for the transplantation. And if they are ready, if they are capable of getting it done, then it should be done. Nowadays, various liver transplant centers offer transplant at very low cost also because they have money which have been donated by somebody. The only thing is that post-transplantation, the child requires medication for around 8 to 10,000 per month. If the family is ready to afford this much, then only they should be sent for liver transplantation. Because liver transplant, just getting liver transplantation is not a solution. You have to manage the transplantation also post-transplant. If the immunosuppressants are not given, then this is as good as not getting it done. In fact, it is worse than getting transplant getting done if you are not able to manage the immunosuppressant. So if because acute hepatitis A induced liver failure offers very good prognosis after transplantation. If the parents are capable, then they should definitely be sent for transplant as and when required. Thank you.
And we can stop sharing. Yeah. I think there is a question for you. Is there any role of probiotics in the event of compromise of liver function?
Sorry, what's the question?
No, I think the moderator can tell. I think I'm interfering the moderator role. Sorry. Is there any role of probiotics in the event of compromise of liver function?
As of we talked today, there's no role of probiotics in improving the liver function. There are various studies which are going on, and there are theories coming up which say that the cause of liver compromise could be the change in the probiotic. And few studies are there, but as of now, the answer would be no.
Thank you very much, ma'am, for an informative lecture. I think most of us have understood that we should wait we should repeat the hepatic enzymes and wait for it to be normalized. And second thing, we should rule out the underlying cause and refer timely for if INR is increasing more than 4 and prepare the child for transplantation if required. And I would like to move to the next lecture. The next speaker is Dr. Sachin Patil, who is one of my close friends, and he's the backbone of this module. He's an enthusiastic pediatrician practicing at Patil Kids Care, Yavatmal. He's a consultant at Sanjeevan Multi-Speciality Hospital. He's national coordinator for picnic module. There also he has done very well. He has coordinated many picnic modules. He's a master trainer for EPIC, BCNRP, and BLS. He's a secretary. He was secretary for Yavatmal Academy of Pediatrics in 2018. Over to you, Sachin.
Thank you, Sachin, for sweet and lucid introduction. Good afternoon, everyone. We will go fastly because we are 30 minutes lagging behind. In this session, we will discuss regarding the just 1 minute. I am audible, Sachin? Hello?
Yes, you are audible.
Yes, Sachin.
Okay. Oh, yeah. Thank you. In this session, we will discuss regarding the hepatitis A vaccines, then latest WHO and IAP recommendations regarding the hepatitis A vaccination schedule, and some peculiar points for IAP Corrigendum 2020. WHO recommends that vaccination against hepatitis A virus to be integrated in every national immunization program after the age of 1 year. And the basis for this indication is the incidence of acute hepatitis A remarkably changed. Like in India, it's from towards high endemicity to intermediate. Then countries with improving socioeconomic status may rapidly move from high to intermediate hepatitis A endemicity. In these countries, a relatively large proportion of adult population is susceptible to have hepatitis A virus infection, and hence we need a large-scale hepatitis A vaccination. Our motto of now India's motto is to eliminate hepatitis A by 2030. India currently has pockets of high endemicity as well as low endemicity, and hence there is always a risk of hepatitis A in older children and adults. Hence, exposure in low endemic population can lead to outbreaks, which is very dangerous for our country. As we know, there is no active treatment of hepatitis A virus. Hence, prevention is the best modality to get rid of the infection. Hepatitis A is endemic in India, especially several outbreaks was there in various parts throughout the past decade. Almost 50% of children of ages 1 to 5 years were found to be susceptible to hepatitis A virus. Hence, hepatitis A vaccine is effective? Yes, surely it's very, very effective. This is the small graph of study which is done in China, showing that as the coverage of immunization is increased, the incidence of hepatitis A decreased dramatically. The same studies are done in hepatitis in US.
Sachin, sorry to interrupt you.
Yeah?
Actually, your screen is not showing. Your screen is not shared. Yeah.
Okay. Now?
No.
Now?
No.
Just a minute. Is it visible now?
Yes, Sachin. Now it is visible.
Okay. Just a minute. Visible now?
Yes.
Visible now? Okay.
Yeah.
This is the graph showing the which a study was done over in China, where as the vaccination of hepatitis A increases, the incidence of hepatitis A virus infection is decreased dramatically. Similar studies was done in other countries also, like US, and all indicates shows that recommendation for hepatitis vaccination has caused us dramatically decrease in the reduction in the acute infective hepatitis A incidence. Hence, we should give hepatitis A vaccine to everyone. There are almost two types of hepatitis A vaccine. One is inactivated kill, that is formaldehyde use, and another is the live attenuated vaccine. All hepatitis A vaccine contains antigens derived from attenuated hepatitis A strains grown in the cell culture. Vaccines can be segregated into two general categories like live as well as inactivated. It has been assumed that live attenuated vaccines are superior to inactivated vaccine in terms of quality of antiviral immune response, the level of protective immunity, and duration of protective immunity. We will discuss in next slide. Although the most current vaccines induce antibody-dependent immunity, many vaccinologists still believe that a live virus vaccine is needed to induce strong T-cell response, as well as strong T-cell response are required for protective immunity. This is the difference between the live attenuated hepatitis A vaccine and inactivated. Live vaccine almost resembles natural infection. It gives continual antigenic stimulation, giving sufficient time for memory cell production, provides cell-mediated as well as humoral, both immunity, and same dose for pediatrics and adults. But in inactivated, does not resemble natural infection, does not like vaccine. It's being kill one, provides humoral immunity and very weak cell-based response. And dose is different for pediatrics as well as adult population. The inactivated vaccine, the dose will be high. Number of doses will require 2. Need of adjuvants is there. The duration of immunity in inactivity is somewhat less, but humoral immunity is good, but cell-mediated immunity is poor. The route of administration in kill one is intramuscular, and the minimum age is more than 1 year. Compliance somewhat difficult because it requires at least 2 doses. But in live, we need only 1 single dose. It's a subcutaneous vaccine. Hence, the compliance is more. Live attenuated H2 strain hepatitis vaccine, some peculiar features that it's licensed for use. More than 160 million doses are administered successfully. PSUS establishes the safety, and apart from China and India, this vaccine is registered in Philippines, Thailand, Nepal, and Bangladesh. This is the graph which was initially I have shown you. The incidence of hepatitis A almost decreased as soon as the immunization of hepatitis A is increased. The study shows that there is annual morbidity which was associated with hepatitis A virus was almost decreased by 91.2%. So these two studies, China, the effectivity of the hepatitis is much more proved. Hence, WHO in 2012, they have mentioned the paper that live attenuated single dose and inactivated hepatitis A vaccine are safe, highly immunogenic, possible, provide long-term protection, and more effective in hepatitis A against in children and adults. A single dose regimen has been successfully used. At the same time, IAP also mentioned that after 1 year, the single dose of live attenuated vaccine like H2 strain or 2 doses of killed one are having a good result to prevent the hepatitis A infection. This was we all know that this is the IAP guidebook which was done in 2018 and 19. There was some dose was wrong, like it's a 2 doses for killed one. Hence, the IAP statement has corrected in Jan 2020. Now they had mentioned that only a single dose is recommended for live hepatitis A after 1 year. In short, the WHO mentioned after 1 year live vaccine only 1 dose is required. At the same time, IAP, an advisory committee for vaccination of IAP also recommended only single dose for live, and for killed one, WHO mentioned that there should be 2 doses which should be separated by 6 to 12 months or maximum 18 months. At the same time, IAP also says that 2 doses of killed one 6 to 18 months apart. Hence, hepatitis A vaccination schedule for routine vaccination, minimum age is 1 year. Start with 2 doses of inactivated hepatitis vaccine for age 12 to 23 months. Separate the 2 doses by 6 to 18 months. For inactivated vaccine, 2 doses are required, a single dose for live one. For catch-up vaccination, administer at least 2 doses of inactivated vaccine, which should be separated by 6 months. But if it is live vaccine, you can give only single dose. Now the era is of vaccination. We all know everything is regarding now COVID vaccination certificate. Hence, we also immunize every children more than 1 year to prevent hepatitis A. Thank you.
Thank you, Sachin, for such crisp and clear views on hepatitis A vaccine. Our next speaker is Dr. R.K. Gupta, sir. He is Senior Professor and of Pediatric Medicine, SMS Medical College, Jaipur. He is in charge of Pediatric Gastroenterology Subdivision of SPMCH Institute, SMSMC, Jaipur. He was National EB member IAP 2010, 2013, 2015, and 2020. He is National EB member North Zone Medical Education Chapter IAP 2021-22. President Pediatric Gastro Rajasthan, President Celiac Society Rajasthan 2019 to 2021. He was President IAP Jaipur 2011. Having 25 years of postgraduate PG teaching experience as a regular faculty in SMS Medical College, Jaipur, has been awarded FIAP in 2011 by IAP. More than 45 papers in indexed medical journals, has been national trainers in more than 20 CIP programs, has been joint organizing secretary National Pedicon 2010. Sir, on behalf of IAP and IMA BID, I welcome you for the next talk. Thank you.
Thank you, Dr. Rag. Thank you very much for a nice introduction.
And my sincere regards to Dr. Sachin Patel and whole the organizing team for giving me this opportunity, and also our President Ramesh Kumar sir and our Secretary Dr. Vineet Saxena sir. And my sincere regards to the formation of this module, which is such a beautiful module. And regards to Dr. MGM, Dr. Ravi Shankar, Dr. Sachin, and Dr. Ramakant, Dr. Vaidya, all who are present here. Thank you so much. So the topic given to me is about the hepatitis A vaccine, especially the live attenuated vaccine. So we will discuss about this, that so we'll discuss that what are the various clinical studies about the live attenuated hepatitis A vaccine. Just now, Dr. Patel has told that the live attenuated hepatitis A vaccine is efficacious, and in the China there are more than 23 years studies. So we'll discuss more in detail about the live attenuated hepatitis A vaccine in this presentation. So this vaccine, this live attenuated vaccine, it simulate natural infection. So it's a live vaccine, so all the things orophycal route, and it simulates natural infection. It produces a complex immune response, which is unlike of the intramuscular vaccine, that is the injectable one. So this complex immune response comprised of IgG, IgM, IgA, all things. So it's humoral as well as cellular immunity. And this H2 strain is licensed for above age 1 year, as with the killed vaccine. But here it is a single dose which can be given subcutaneous deltoid. So this is the thing. So it simulates natural infection, though the natural infection is orophycal. Here we are giving it by the subcutaneous route, but it's the live vaccine, so it simulates natural infection. And the freeze dried is there. And you can see the same dose is for adults and children. So unlike in the killed vaccine, you can use the same dose. So these are the summary about the things. So hepatitis A live vaccine safety. So seroconversion with live attenuated hepatitis A vaccine. The first study was done in, you can see in the 1990 December. So in which 3,089 candidates in the 3 batches. And the seroconversion occurred at a mean time of 2 to 5 weeks. So very early seroconversion after inoculation, and the positivity was 95%. And no local or systemic reactions during the 42 days follow-up. And even the serum enzymes remained within normal range. So this is a very good safety profile, which was published in 1990. You can see it's more than 30 years back. Then another study which got published in 1992. This is the immunogenicity, when the seroprotection cutoff was taken as 20 milli-international unit per ml, and 11,000 healthy adults in 3 batches with the seroconversion rate of 93%, with the quick antibody response in 2 to 5 weeks. So candidates were 3,000, here they were 11,000. So, and this is the one of the earliest human trials were conducted in a small sample size, wherein the total 12 subjects, 8 women and 4 men, 18 to 27-year-old, all seronegative for hepatitis A. And all the 12 subjects were found to be seroconverted within a mean onset of 3 weeks post-vaccination. So this you can see 90 to 100% conversion. Here the immunogenicity is 92%. Here the immunogenicity is 95% in a various studies. So what about the protective efficacy? Now, after getting the immunogenicity, we are discussing about the protective efficacy. So this hepatitis A live vaccine, the 4-year study in 1989 to 93, which was published in 97, the protective efficacy was done in 11 primary schools. It was studied in the Xiaojing County of China in 6,000 children. So no HA case reported in 18,100 cumulative person years in the vaccinated group, while 495 among the 2 lakh cumulative person years in the control group. So you can see in the vaccinated group, now no patient, nil, 0. while in the control group 495. So you can imagine how much is the protective efficacy. And a large scale vaccination with the cumulative vaccination coverage of 89% was carried out in the Zhejiang city in children 1 to 15 years. And hepatitis A in this age group, which had 12 to 87 cases per annum for 8 years before vaccination. So this was with the before vaccination 12 to 80 cases, average 32 per year, which decreased to 6 cases over the period of 4 years or 5 years, 91 to 95 after rising vaccination coverage. And all these 6 were non-vaccinated because the vaccination coverage was 89.45%. So you can see it's almost nil cases in vaccinated group, and post-vaccination only 6 cases, that too all in the non-vaccinated group. So you can see the protective efficacy. It's such a nice protective efficacy, and this was published in 1997. This is an open level evaluation of immunogenicity and safety of BioVac A or the hepatitis A vaccine in the healthy children. This is from India. So Sheila Bhave et al. Published in 2014, and 2 centers, Calcutta and Pune. So 137 children were included, all 1 to 12 years age, and the single dose was given. And after 8 weeks, seroconversion was seen. So you can see in the code, Kolkata 100%, Pune 98%, and average 99%. With the GMT, average GMT is 78.4. So you can see it was a bridging study. So you can see a single dose of live attenuated hepatitis A vaccine produced an excellent seroconversion and had a good tolerability profile. So immunogenicity and safety of live attenuated hepatitis A vaccine multi-centric study. This was another study which got published in 2015 by Mitra et al. This was again a multi-centric study with the Calcutta, Chennai, Mumbai, and Pune. In the previous one, Calcutta and Pune. Here, New Delhi, Mumbai, Chennai, and Calcutta. Again, a 5-year study from 2008 to 13, and 343 children were seen, 18 to 60 years age group, 60 months age group. So 1.5 to 5 years. And they were followed for 5 years, and a single dose was given. Now 9 years have completed. So you can see up to 5 years at the time when this study got published. So you can see 95, 97, 98, 96, 97, 97. So seroconversion was more than 95%, which persisted even up to 5 years. And the GMT titers were pretty above the cutoff, that is 20. It was at 6 weeks, it reached to 60 plus. And after the completion of 8 weeks, you can see this reached to 100 plus every time, 6 months, 1 year, 2 year, 3 year, 4 year. So it's a very nice titer you can have. So good seroproduction rate of 97% and the GMT 127 at the end of 5 years. So this is the evaluation of immunogenicity and tolerability of a live attenuated hepatitis A vaccine in Indian children. This is the single center, non-randomized, open confirmatory trial for a period of 10 years, 12 months to 12-year children received single dose of hepatitis. This study was done by Sheila Bhave and it was published in J Indian Pediatrics. And this 121 were evaluated for 10 years and 115 were evaluated for 12 years. You can see again the protective seroprotection, 95%, 92% at 3 years, 6 years 77, and it raised again to 87% at the end of 10 years. So you can see it's pretty good seroprotection, and the geographical mean titers 111, 66, 100. So titers are more than 100, more than 5 times of the normal. So this you can see. So the 13 cases, if 13 vaccine failure excluded, the rate reached to 98% in 2014. So in the 13 cases, vaccine failure was, I do not know this how this vaccine failure occurred. So 98% seroprotection was there. So good seroproduction and GMT at the end of 10 years. So long-term immunogenicity of single dose of live attenuated hepatitis A vaccine in Indian children results of 15 years follow-up. So that again from that Sheila Bhave madam and from KEM Pune, so 109 completed this 15 years follow-up. We were discussing 87.6, 77 in the last slide. Now the 15 years have completed. You can have still very high seroprotection and very nice GMT titers, that is 79 and 86. Not a single case of hepatitis A infection in study subjects in 15 years. So single case of hepatitis A, nothing happened. So it's very good, very nicely, very nice, effective vaccine. At the end of 15 years, GMT was this much. Evaluation of tolerability. After seroprotection and efficacy, now issue of tolerability. Because every vaccine should be tolerable also. There should not be any significant side effects. So again, no immediate or delayed reactions and no serious adverse events following vaccination in any of the study children. And hematological and biochemical. We expect it's a live vaccine for hepatitis A. So at least SGOT, SGPT, bilirubin, alkaline phosphatase should rise slightly, but no rise. You can see in this table. So at the baseline and at the end of trial, they were within normal limits. You can see the AST 31, 32, 17, 15.6, bilirubin 0.4, 0.5. So HB same. So there was no change in the hematological or biochemical parameters, no clinically apparent immediate or delayed reactions, and no serious adverse reactions. So this is the immunogenicity, immune protective efficacy of live-related hepatitis A vaccine and the 15 years follow-up. This is again a Chinese study, a landmark study. Zhuang Si et al. From this study was done in Zhonghua area, and this you can see that even after 15 years of the inoculation, the 96 subjects, 81% was the seroconversion, and GMT was 128. Sorry, I'm so sorry. So 2 months, you can see 220 patients, so it was 98, and even after 15 years, the efficacy is very nice. So in the Zhejiang district, immune barrier was set up and no outbreaks happened. So this is very important. So when you are giving live vaccine to 80 or 90% of the age group, it leads to immune barrier. So hepatitis A morbidity of people decreased 96.7%. All the inoculated people did not had hepatitis A. So that proved that the double protection of the hepatitis live vaccine and both humoral and cell-mediated immunity was there. So it's a double protection because of the vaccinated people as well as breaking the chain. So you can see the seroprotection was very high. Now, one important thing, immune memory. So immune memory after a single dose. So to assess duration and characteristics of immunity conferred by this vaccine, and 3,515 hepatitis A susceptible children 1 to 12 years were enrolled between 1996 to 1999 and were randomly assigned to receive a single dose of hepatitis A vaccine or control. So hepatitis A vaccine recipients, either without natural infection or vaccine boosters, were selected as participants. So no natural infection or no vaccine booster. The booster dose was administered immediately after collection of a blood sample, and the second blood sample was obtained 2 weeks after. So as per WHO guidelines, required level for seroprotection is 20. For any vaccine or post-infection, antibody titers will start falling after some period. After long duration, what is the actual clinical effectiveness of the live vaccine in real-time scenario? So real-time scenario comes into effect when even after 10 years of the vaccination, 15 years of the vaccination, when you are exposed to virus, then what happens? So to see what if the GMT titers are below recommended less than 20. So if the people are having less than 20 or more than 20, so then what is the reaction to hepatitis A exposure? So anti-hepatitis, anti-HIV negative were those in which the GMT was less than 20, and anti-HIV positive were those whose GMT was more than 20 after 17. So 18 people anti-HIV negative before booster dose, and we have given booster dose to 13 of them. So at that time, in the negative people, the GMT was 7.6. And at the time of, so we got the thing that after giving this booster dose after 17 years, you can see the HIV levels rose to 661. So antibody to hepatitis A, it rose to 661 from 8. We compare anti-HIV positive, those who have been having the positive antibody titers more than 20. We inoculated booster dose to 18 of them. And when the average was 67, it reached to 1,800. So it rose significantly, but from negative to it became a very, very high 661. It was expected, but this was not expected. So it shows that the memory, it's a very nice memory even after your antibody titers are less. So immune memory at the end of 17 years. This has been proved by this study done by Ying Shan from China. This you can see graphically. So this study shows that these children produced cellular immunity is also a good role in the memory cell activation, and the antibody titer in the negative group was very low, but there was no significant difference in terms of protection between the two groups post challenge or the post booster. So this is the discussion and this is the explanation. It may be increase in the secretion of interferons by CD3 positive T cells, and it was measured after booster dose. And this CD3 CD8 subset was remarkably higher than those for CD3 plus CD4 plus subset, which satisfied the characteristic of live attenuated vaccine to mediate a cellular-based response. So this shows that the CD3 plus CD8 subset, so it's the cellular response, and antigen-specific memory, both memory cells, B cells and T cells were formed. So this is very important to know. And the single dose of hepatitis A vaccine shows good B cell and T cell memory. This is the summary of all the trials. So most of the trials were in the China, Jiang, Liu, and in the India one, but cohort studies were done. China, Yang, Liu, Jiang, Mao, Chuang, all very big subject numbers. But in the India also, Bhave, Swati, Sheila Bhave madam, and this Faridi and one Mitra. So there are few studies in India also about the hepatitis A, and they have said about the value of the thing. This slide has been discussed by Dr. Patil, that live attenuated vaccine, a single dose at 12 months. And this is same in the WHO and IAP. And while the kid vaccine 2 doses, that is 6 to 12 months apart, maybe up to 18 months apart. So in the 2016, the IAP recommends live attenuated vaccine a single dose. So these are the changes, so that you can have that at the age of 12 months onward, live attenuated vaccine can be given subcutaneously and the single dose is sufficient. There is no need of giving two dosage. While in the killed vaccine, the first dose to be given at 12 months plus, and after 6 months to 12 months, the second dose is to be given. So that is the killed vaccine. So this is, you can see in the table, 12 months hepatitis A single dose, 18 months hepatitis A second dose, but only for inactive hepatitis A vaccine. Take home message, the hepatitis A case mortality increases with age. And the fulminant hepatitis A is rare, but considering the volume of hepatitis A infection, it is significant in our country and it is associated with high mortality and morbidity. India has moved from high to intermediate zone of hepatitis A endemicity because of improved sanitation, hygiene, vaccination. So good sanitation, good hygiene, and the use of these sanitary latrines and this open air defecation is abolished. So that has led to all these things. And the single dose is adequate as per WHO as well as Indian Academy of Pediatrics, and it produced both humoral and cell-mediated immunity, and required protection is 20, but you have seen that even after 15 years, we can have a pretty good GMT titers. And the only hepatitis A vaccine is backed by the Indian trials. We have 5 years multicentric and 15 years unicentric trials also. And it is advantage of longer protection because of the memory cells. So this has advantage of less pain because of the subcutaneous route and the single injection only. So thank you so much. Thank you so much for giving me this opportunity.
Thank you, Gupta sir. It was a very nice presentation with lot of studies in between. So I think most of us are clear that live attenuated vaccines, single dose, will have both cellular and humoral immunity, and it will give long-term protection. So with that, we will move on to the next speaker, Dr. Ravi Shankara sir. He is a DCS DNB and fellow IAP. He is pediatric allergist, HOD, Department of Pediatrics, SS Persh Hospital, Bangalore. He was president of IAP Bangalore for year 2020, and he is president IAP Infectious Disease Karnataka State Chapter 2021. Over to you, sir.
Thank you, Sachin. Hope my slides are visible and I'm audible. Both are okay. I think so.
Yes, sir. Audible.
Thank you for the many audience still staying there. This will be the last topic. Though it's the last topic, but not the least one. Some important topic is there in this one. And meanwhile, let me thank Dr. Basaraj, who was the coordinator during when this TOT was prepared, and Dr. My Guru, Dr. Bhaskar Shane, and Sachin Patil for giving me this opportunity. See, many times we go, all of us, now it has become a habit to all of us, at least to go outside to have food in a week and have food, enjoy. We will see the lights flashing there in the hotel or on the roadside. So we'll look at the seats and everything. But anytime did we look into an ad or a post in the hotel or wherever you go that all the workers in this hotel are vaccinated with hepatitis A? I don't think we have done it. Because in fact, I myself didn't do it about 2 years back. Nowadays, we can see a lot of posters in the hotel that all the people are vaccinated with COVID. So because the government made a rule that everybody should be vaccinated and give courage to us because we know the havoc the COVID has created with us, that's the reason we are more bothered about that one. But we never bothered in last 10 years or 15 years whether the same workers are vaccinated with hepatitis A. Because we didn't see much, we thought there are not much cases of hepatitis A, but the data disproves that a lot of hepatitis K are there, and they were admitted, and a lot of man-made, no, what they call holiday years were lost, but we didn't bother about it. So this topic was just focusing on that on that subject, there where we had to prevent a hepatitis A at any cost, and also safeguarding our adolescent people who are more prone to go outside and have the food, enjoy the food with their friends instead of having the food in the home. So let us look into this topic. So this is the common scenario when I was in MBBS when joined, and many people getting infected like that. And I am sure some of you also had the same scenario in who are there in the hostel. That is 18 years old male, recently joined MBBS and staying in the hostel, developed a fever, vomiting, loss of appetite, passing yellow colored urine. 3 days later, sclera became yellow. Lab investigations um, uh, came positive for hepatitis A. Serum bilirubin high, SGO10, SGPT increased. So this scenario, many times we had seen in our hostel life. At least I have seen many times. And this is also a story of my cousin who got admitted in Bangalore Medical College, and he developed that one. That's the reason I put up this slide. So what are the three things here? What exactly is happening? There are three things in this case: an emotional aspect, the financial aspect, and absent for the study. The emotional aspect is very huge because we are moved from our native place, come to another distant place, and nobody is there next to, no family members next to us, and in the hostel we are staying, and the good friends of us who are our roommates or neighbors, they will come and look after that, and the parents will be in distant far off. They'll be very much, because in India we know the jaundice means it is something a very serious matter. The parents are suffering there, so that emotional aspect. And the financial aspect, the person will get admitted, and lot of investigations, treatment, everything done, and that aspect also is there. And absent for the study. Remember, sometimes it happens during the exam time, 1 month before or just 15 days before, something imagine the situation, or just 3 months before, or when something is serious, posting is there, and got the, so absent for the study for about a week, and afterwards bed rest for that one. So this aspect we never bothered about it. So the time has come for us to bother about this aspect of vaccinating the people who are the food servers, except especially the Zomato has come, Swiggy has come. He will come and he'll hand over the packet to us. We don't know how they are prepared in the hotel before transferring the food to the Swiggy man. Have they utilized all the good hygiene aspects in that one? None of us know about it. So the time has come for us to bother about this aspect. The emotional, financial, absent for the study is the important things. We know already, it is told here by the previous speakers, it is a waterborne and foodborne. So that's where the problem comes. The water they prepared for the food, we don't know how, from the source of water. Many times you might have seen in the WhatsApp, that is to prepare the what is that, pani puri, bel puri, to make it very tasty. Somebody utilized their drainage water. It has come in the WhatsApp everywhere, even in the media also. So what is the food, the source of food, water we don't know. And the foodborne, whether the vegetable, how they clean the vegetables, that also we have seen in the media, in the WhatsApp, everything. Cleaning the vegetables in the drainage water and bringing that one. Everything we have seen it, but none of us bother about it. What precaution we can take about that one. So the time has come for us to bother about that one. So it is a waterborne and foodborne. Everything is told by the previous speakers. So what is the, look at the last paragraph. At this stage, the disease is asymptomatic and provides lifelong protection against the disease. That is in the initial stages when it comes in the childhood, that is at the 1 year or 2 years, it is asymptomatic and provides lifelong protection against the disease. But what happens, it comes in the adolescent. That is an important aspect, we'll bother about it later. So according to the global estimates, approximately 600 million cases of foodborne illnesses related to 31 pathogens are reported annually. So imagine that, what is a huge number, 600 million. If you convert it into lakhs, it is 6,000 lakh cases. So that is the estimate all over the world we have got it. And it is just caused by 31 pathogens. So that's all, nothing else, that one. And of which, out of the 600 million, 14 million, that is 140 lakh cases are due to HIV infection. And look at this number, it is almost 1.3 lakh disability adjusted life years are lost. That is the important aspect. We get admit 1 week, then the bed rest for us, because it is jaundice, give rest to the liver. So 2 weeks, 3 weeks bed rest. What exactly is happening? That is the important aspect of this hepatitis A. And remember, out of the 31 pathogens, HIV is the probably one that is a vaccine preventable one. So we had to bother about this vaccination of our adolescents, the food handlers, and everybody. So this is just a slide to show that one. What are the organisms we are causing? There's the bacterial, bacillus, streptococcal, ETAC, staphylococcal, Vibrio cholerae. So of course, Vibrio cholerae has got a vaccine, but we are not giving it so commonly. And Salmonella typhi. So these are the things. And in the viruses, hepatitis A virus is the only vaccine preventable in the adolescent age group. Whereas rotaviruses, they're in the infant age, but whereas the hepatitis A is vaccine preventable among so many parasites and viruses, we have got that one. So now what exactly is happening? Once upon a time, when we used to, children of my age, I'm telling, so go to school, come back to home, have the food in the home, whatever the mother prepared with love and affection, she used to give it with clean hand and everything. We used to have it and sleep in the home. So that was the situation about 20, 30 years back. Now it is a rapidly changing socio-economic development, and especially in the urban areas like Bangalore or what are the districts headquarters like that. Here the students want to have the food outside. So that is a rapid socio-economic development is there. And financially also they are more, eligible, more confident of spending the money outside the home and have the food like that one. So at these ages, infection carries, so by chance the infection comes at this adolescent or the early adulthood age, what happens during that time? At these ages, infection carries a higher risk of symptomatic disease and complications, including mortality. So compared to the childhood, when the same disease comes in the adolescent age group, there is a symptomatic disease is very high, and complications are also high, and mortality is also high. So all the three parameters will be more when the patient gets in the adolescent or the early childhood age group. So globally, what is happening? Food contaminated with HIV account for 2 to 7% of all HIV outbreaks. That's what I told. Almost 16 million. That's what we saw in the previous slide. So infected individuals may require hospitalization, which places a large strain on individual households' expenses. That's already been mentioned, financially, emotionally, and loss of days. So let us think about the two things, spreaders and receivers. So we are the people who are going to the roadside hotels or food caterers or to the hotel also, and we are the receivers. And the spreaders. Spreaders are the one who is serving the food to us, whether it is a Swiggy man or it is a Zomato man or it is a roadside hotel or whoever it may be, he is the spread. So that is the person, and also the food preparers. So spreaders include the food servers and the food preparers, how they are preparing the food, how they are giving the preparing the food, how they kept the food, and how they are serving to us. So all the three aspects come there. So in India, what is happening? Most food handlers are adolescents and young adults who might be exposed to unsatisfactory environmental conditions and poor water quality. This is an important aspect. When we go to outside, the server who is serving the food is most of the times an adolescent one or an young adult, and they are come from a little poor family. So they are exposed in what is there in the family, we don't know. What is their home, what is the quality of the water they use, the food they use, how they are handling the food, how they're keeping their hand hygienic. We don't know anything about that. So outbreaks due to the foodborne hepatitis A virus have been frequently reported in India, with adolescents and adults primarily affected. This is what we are seeing nowadays during the monsoon time. So look at this slide. This is the slide where the statistics done. So percent of HIV induced acute viral hepatitis, what is the percentage? And here is the age group. In the horizontal bar, you can see the age group. That is less than 15 years, more than 15 years, and 13 to 20 years. Look at this bar. This is a huge one. So here whatever the people, the percentage of the HIV-induced AVH is more common in this 13 to 20 years age group. So this is the adolescent and early adulthood age group. So in this age group, the HIV is causing the infection, acute viral infection. So after seeing this data, let us go to the other things. The food handlers play a major role in preparation of the safe food, and they may transmit HIV to susceptible individuals if infected themselves. So all the parameters, how the food is, the origin, the raw materials gave to them, how they prepared it, and what are the quality of the water they used to that one. These are three important things. What is happening in India is most of these servers, the cooks and everybody they are somewhat uneducated. That's what I can, of course, maybe you can see some educated people, somewhat uneducated. Even then educated, with respect to the hygienic condition, they lack knowledge. That is an important aspect. In India, lack of knowledge and awareness of preventing foodborne diseases and practice of proper hygiene among food handlers is a major concern. This is the most important thing. So being doctors, we should tell to our local MLAs, the corporators, everybody about this. Fortunately, in my area, Rajareshnagar of Bangalore, the MLA is so good. So in this area, he is making that one, all the roadside food people, the food servers, serving people and the hotels, they should comply with the FSSAI rules. I'll tell what is FSSAI rules later. So that's the reason we can even if go to the last week I went to have the food by the roadside. There I can see in his what was the Gaudi, whatever all the what are the thing he had that one. I am complying with the FSSAI rules. He has put up that thing, and the FSSAI has given certificate. The municipality, the Bangalore corporation has given the certificate to them. So the young and economically active population, this is an important thing. See, according to the recent census, what is exactly happening? India has a population of roughly 1.38 as 1.4 billion, out of which 63.7% belongs to the 15 to 59 years of age, and they are economically active. It is not that they are dull, they don't have the money to buy the food outside, they are economically active. And the second thing is they are moving population. So, and their social and cultural behaviors are changing. So in recent years, India has undergone rapid socio-economic growth resulting from increasing trade and industry, increasing degree of modernization, and access to better education, health services, housing, nutrition, technology. We can see a lot of residential school has come up, lot of medical colleges, engineering colleges, MBA colleges, they'll go outside. And when they are going outside, they are far off from there. Even within Bangalore, if I go to another 20 kilometers, means it takes about 1 to 1.5 hours. Meanwhile, I may get hungry. I will try to have the food outside. So having the food outside has become an increasing tendency nowadays. So, and the spending capacity has increased, that's already I told. And look at the last paragraph. Between 2010 to 2019, the Indian railway network transported over 23 million passengers every day. This is an important statistics, 23 million passengers every day. And how many will have them food outside? So that is the important thing. And 993 universities, almost 40,000 colleges, 10,725 standalone institutions in India are there. So the students are going there. Meanwhile, they'll get angry. They'll go to our college canteen. They'll have the food. So the tendency is there to have the food outside. Whether the same tendency is there with the food servers to maintain hygiene and immunize them, we don't know. That is the problem. So percentage of respondents eating out in a week per age group. Look at this bar. So at least the blue color belongs to the less than 20 years. That is a huge. In almost all the bars, they are the huge numbers. So minimum is 1 to 3 times per week they will have the food. 4 to 6 times maximum. 13 to 15 is also there. So all of them, most of the time they belong to this age group of less than 20 years. The next is 20 to 30 years. So let us come to the what exactly a food outbreak. So according to the definition of the NCDC, that is National Center for Disease Control, an outbreak is when 2 or more cases of a similar illness occur after the consumption of a common food, or the observed number of cases of a specific disease exceeds the anticipated number. So in the same hotel, the food joint, the people, if you get 2 or more cases, that is a food outbreak. So there is something wrong in that food joint. So whatever the food he has prepared or is not hygienic, the person who is serving is also may not be hygienic. That's what we have to keep it in mind. So according to the NCDC, same NCDC, there were a total of 315 outbreaks of viral hepatitis between 2010 to 2013. That is, within 3 years, there were almost 315 outbreaks were there. And HIV was responsible for 10 to 30% of acute viral hepatitis cases, and 5 to 15% of acute liver failures were due to HIV. So these cases could have been prevented if both were vaccinated, both the receiver, the person who is eating there, and the person who is supplying the food there. If they were just used just 1,500, whatever the 2,000 rupees on vaccine with a lifelong protection, we know about it. If they are done, probably we could have avoided this situation. So let us think of the strategies to prevent food outbreak. So what are the strategies are there? Strategies to prevent HIV infection and transmission are urgently needed in the country, because we know the population is there, economic viability is there to eat outside. So the phrase from farm to plate and make food safe, probably a good idea in almost in all the media, everywhere they can put up this board. And as it could help in developing a preventive strategy composed of different complementary measures, such as improving the sanitation, which is already highlighted. The sanitation has to be improved, access to clean drinking water, and even the same clean water should be there to wash the vegetables and everything, to maintain, to prepare the food also, same thing should be there. And maintaining healthy food and water hygienic practices, and the last one, but not the least one, and the very important one is immunization. So the government of India, already we know, as soon as in the last 10 years, they came out with the slogan Swachh Bharat Mission. I don't know how many really interested. When Swachh Bharat Mission came, we didn't bother about it much, but we will understand the importance of Swachh Bharat Mission once we come to know about these outbreaks of food outbreaks. So this is a very important thing. We had to follow this one. The government of India is doing that one. And National Rural Drinking Water Program is also next another program where the potable water should be there to all in the village areas, semi-urban, urban, everywhere. So this is the important thing. And the third thing is educating the people about that one. So regulation by FSSAI and Bureau of Indian Standards are available. They should be known to by the local municipal doctors or who are there, and they should highlight to the local MLAs, corporators, other government officials about this one, and they should strictly follow these guidelines with respect to the food joints. And food industry and the public should follow these guidelines from time to time. And then the last thing is the vaccination. So there is, take this example, hepatitis A outbreaks in St. Louis occurred. So when the when that led to the implementation of mandatory hepatitis A vaccination of the food handlers, then the case rate of hepatitis A dropped from 3 per 100,000 population during the pre-hepatitis vaccination period to 1 per 100,000 population. Almost 2 people escaped by having the vaccination. This is an important measure, so that we had to follow about it. The remaining 2 also can escape if you follow a good hygienic practice. So hepatitis A vaccination has favorable cost effectiveness in middle income countries if they are of high and intermediate endemicity. Remember, by just giving a vaccine which is maybe 2,000 rupees to their workers, the food joint owner saving a lot of money, because if the same person get infection and get admitted, he has to look after them. Instead, giving the vaccines to all of them is an important thing. Probably the food joint owners also will come to know about it, and we, the food eaters in those things, should enforce and should forcefully tell. I mean, forcefully means very decently we have to tell them to go for the vaccination. So So vaccination is the immediate benefit. There is no doubt about it. And the vaccination of food handlers to prevent the spread of HIV across the country could potentially be the cost-effective measures. Thank you a lot.
Thank you very much, sir. I think everyone know now ki sanitization and vaccination of food handlers and hostelites is very important. If you want to go out and study, or if you want to have food outside, you should be vaccinated. Now, quickly, we will move on to the last lecture by Dr. Sachin, who will summarize all the entire module in a short time.
Thank you, Sachin. I'm audible, Sachin?
Yeah.
And visible also, presentation?
Yes.
Okay. Yeah. We all know a marathon show was done almost. These are just a few 5 to 6 slides of entire module, the take-home messages. We all know that hepatitis is an inflammation of the liver that can cause mild as well as severe illness. Hence, HIV is transmitted through ingestion of contaminated food and water and through direct contact with the infectious person. Almost everyone.
Sachin,
Yeah.
Sorry to disturb you, but
Yeah.
तुझा presentation mode होत नाहीये.
Okay, sir. Then without presentation mode, I will do. Will it be okay, sir?
Okay, okay.
Just I will increase the. Okay. Audio is there, na, sir? No issue. We have a very 2 or 3 slides are there only. Should I start? Hello?
Go ahead.
Hello?
No, I think you can just
Yes.
go ahead.
Yes.
Can just only 4 slides, you know.
Okay, yes, sir. The risk of hepatitis A infection is associated with a lack of safe water and poor sanitization and hygiene. A safe and effective vaccine is available to prevent this hepatitis A infection. Hence, we know HIV is self-limiting and every patient should be followed till the normal liver enzymes. The most common cause of acute lung failure in a child is hepatitis A infection. Hence, timely referral to liver transplant for liver transplant is must. India is moved from high to intermediate zone of hepatitis endemicity because of improved sanitization, improved hygiene practices, and vaccination. Hepatitis A case mortality increases as the age increases. And fulminant hepatitis, though it is rare, but it is associated with high mortality. India has currently some pockets of high endemicity as well as low endemicity. Hence, there is a risk of hepatitis A in older children and adults. And exposure in low endemic population can lead to outbreaks. As explained earlier, hepatitis A vaccination recommendation by WHO, minimum age is 12 months. If it is live vaccine, single dose, single dose. And if it is inactivated vaccine, then 2 doses. At the same time, IAP also recommends single dose live vaccine and 2 doses of kill vaccine separated by 6 to 18 months. Hence, clean water, improved food hygiene, and mass immunization, these are the tools to prevent hepatitis A elimination, which is the motto by 2030 as described by Government of India. Thank you.
Thank you, Sachin. I think there is one question.
Go ahead.
If a person has already been recovered from hepatitis A disease, should he be vaccinated or not?
No need to vaccination because patient can have a
stop
natural.
sharing.
Yes, patient can have a natural immunity. But we have to first see that whether it is proper hepatitis A infection or other. So we can go serological, and depending on the investigations, we can think of vaccinating or non-vaccinating the baby.
Thank you, Sachin. With this, we will be concluding the session. But before that, I would like to thank all the audience, because all these 3 hours, there was attendance of 200 plus people all over with all the 5 lectures. Second thing, I would like to thank DigiShield platform, which has given us a good coverage for all the speakers. They have registered all the people, and they will be giving us the certificates for MMC accreditation. Third thing, I would like to thank MMC observer, Dr. Shailesh Vaidya sir, and MMC Dr. Dr. Utture sir, who has given us a 1 MMC credit point in very short period of time. And most importantly, I would like to thank all the speakers, CIAP, MAHA-IAP, and IMA BID, because of which I can give MMC point to everyone. And most importantly, Dr. Sachin Patil, who has who because of whom I can conduct this module. This is the first module, CIAP module, being conducted in Maharashtra this year. Thank you.
Thank you. Thank you, ma'am.
Thank you, ma'am. Thank you, sir.
Thank you, everyone, on behalf of Indian Medical Association BID. Thank you.